Welcome, everyone. Just going to give another minute or two for folks to appear on the screen here. Got people traveling through the internet from the waiting room to the main room. It is nice to see some of your faces and your names. All right. We have an action-packed agenda, so I'm going to very quickly run through the tech tools and remind everyone of how we're going to do our mics and video cameras, and then we'll dive right in. Really quickly, I am Jamie Strauss-Clark. I am the facilitator of this CRIS committee. Welcome. This is the Crisis Response Improvement Strategy Committee. I know it can be a little bit confusing with all the committees that we have. Next week is the steering committee meeting. So today it's our Crisis Response Improvement Strategy Committee. Liz, if you could advance the slides, I'll take us through the tech really quickly. So I know you're all very familiar with Zoom, so I won't spend too much time walking you through the tools. For CRIS committee members, if you could keep your mics on mute unless you are speaking, and keep your videos on if it's available to you. That really helps me facilitate, and it helps us engage with each other if we can see your faces. So Liz, if you could click one ahead, that'll just remind everyone where their video is. So this is for CRIS committee members only. If CRIS committee members could keep your videos on if that's available to you, that would be fantastic. Click ahead, please, Liz. We also use the raise your hand function to let me know when you'd like to speak. Again, this just helps avoid us talking over each other. So click on that reactions button. It pops up a window and you can click raise your hand. I always offer this. If you have to make a comment and you can't remember how to open that, don't worry, just wave your hands. I will look for you, and also my colleagues will look for you, and one way or another we will call on you. Today we do have the chat. You're able to chat with any of the co-hosts. So if you have a technical issue or any kind of logistics or technical issue with participating in the meeting, please chat with Brittany. If you click on the chat button and you look for Brittany Thompson's name, she will be available to help with any tech issues, or at least any ones that we are able to solve. If you have a comment, CRIS committee members, that you'd like to make in the chat to me, if you prefer to express yourself in a written form rather than speaking, please chat with me, Jamie Strauss-Clark. I will do my best to monitor that chat. I'll probably pause discussion every once in a while just to run through and make sure I've caught everything there in the chat. And I will prioritize CRIS committee feedback, although I also look for feedback from members of the public. Liz, if you could click ahead. Speaker view, just a reminder, if you would like to see as many CRIS committee members as possible on your screen, you can click on that speaker view and then click gallery and you can see more people. Click ahead, please, Liz. Okay, for members of the public, if you could keep your mics on mute and keep your video cameras off. And it is, as I always say, not that I don't want to see your wonderful faces, but we have 73 people now on the call, and it's going to be very hard for me to distinguish between my CRIS committee members who are participating in today's discussion and members of the public. So it really helps me if you keep your video cameras off. There are a few exceptions. I'll let you know when it's time to click those back on. During breakouts, we'll have an opportunity. I'll be facilitating a discussion with you in the main room, and also, of course, at the public comment period at the end of the meeting. You may also use those chat buttons to check in with Brittany if you have any technical issues, or send me a comment. As I said, I'm going to have to, if I'm getting a lot of comments at once, I'm going to have to prioritize comments from the CRIS, but I will do my best to also acknowledge and maybe even try to respond to some of your comments. At any rate, I will be saving a recording of them, so we will have a record of any comments. Just a last note about ASL interpreters. We always try to provide ASL interpreters, and as you might have noticed in the registration for today's meeting, we asked if there was any need for ASL interpreters. It turns out no one needs one today, or no one indicated that they need one today, which is a good thing, because due to circumstances beyond our control, we were not able to secure ASL interpreters today. So that said, at next week's steering committee meeting, there will be ASL interpreters, and hopefully we won't run into the circumstances that we ran into this time in the future. The other thing I'm going to ask is we are not, in the interest of time today, not going to do what we've done at the past CRIS committee meetings where we ask each CRIS committee member to introduce themselves at the beginning of the meeting. Instead, what I'm going to ask you to do today is when you speak in this room, if you could start by saying your name and your representation on this committee. You can also say what organization you're coming from. That would be really helpful. That'll really help both your fellow CRIS committee members reorient themselves to who's on the CRIS committee and help members of the public know who's speaking. I think that is it. So let's move on to our welcome and introductions. And Liz, if you could stop sharing, I'd like to ask one of our steering committee members, Bipasha Mukherjee, to welcome our CRIS committee today.
Bipasha, you're muted.
Can you hear me now? Awesome.
Yes.
All right. Well, welcome everybody. It's hard to believe that a whole month of the new calendar has already flown by. Welcome back, CRIS committee members. Today we have two new people replacing others on the committee. Welcome, Claudia De Allegri, Senior Vice President, Chief Behavioral Health Officer at CMAR Community Health Centers, representing behavioral health interests of persons of color, and Danny Eagleton, Interim President and CEO at Seattle Counseling Services, representing an organization specializing in facilitating behavioral health services for the LGBTQ community. A warm welcome to members of the public joining us today. I really thank you for your time, your listening, input, and support. Our goal is to help build a stable and flexible behavioral health crisis response system that meets the needs of diverse communities, a system that's not fragmented but functioning like a well-oiled machine across the state. As participants in this process, generously sharing professional, personal, and lived experience is invaluable, but equally important will be listening deeply and using the science and data of best practice as we sort through our systems to see what needs to stay, what needs to be adjusted, what needs to go, and what needs to be added. Let's be real, it's not going to be easy, might even get uncomfortable, but I'd like to keep in mind that our goal is to save lives and help our state thrive because good mental health is the cornerstone to every aspect of life. Let's meet people in crisis where they are at, help them get to a point of stable, long-term emotional well-being. It's what I would want for myself and for those I love. So let's get going.
Thank you so much for that wonderful welcome, Bipasha. So nice to hear your voice again. And then I'd like to ask Representative Tina Orwell to offer our land acknowledgement today.
Thank you. It's my honor. And Bipasha, that was so beautiful. Thank you for that vision. I'm currently in Des Moines, Washington, and that's in the 33rd Legislative District. The 33rd Legislative District is located on the traditional homelands of the tribes we know today as Duwamish, Muckleshoot, and Coastal Salish peoples. We honor and thank their ancestors and leaders who have always been and are the rightful stewards of these lands and waters. We also respectfully acknowledge all of the tribal communities and peoples throughout the state of Washington and give gratitude for their critical role in behavioral health efforts. And of course, I want to thank all the tribal leaders for their work on the Tribal Hub and the 988 line, and we're just so grateful to partner with you. Thank you.
Thank you, Representative Orwell. I'd like to just take a moment to walk us through our agenda for today and make sure that everyone knows how the meeting will proceed today. So Liz, if you could put that slideshow back up, that would be great. Okay, so as a reminder of our objectives today, of course, as ever, we will continue to lay the foundation for collaboration together. You will be hearing some relevant updates coming from Department of Health and Healthcare Authority. And then we're going to spend some time in breakouts discussing your feedback on the initial assessment with a particular focus on issues to be addressed in the next iteration, which will be coming later this year. And then another chunk of the meeting will be spent on providing your input on the issues and priorities that should be carried forward to the 2022 subcommittee work plan, which we expect to bring to the steering committee next week for approval. We will confirm action items and next steps and then hear public comment at the end of the meeting. So Liz, if you could advance, I'll just give everyone the timing on this. All right, so we are moving through our welcome introductions and meeting agenda. Next up will be our personal stories. Two of our CRIS committee members have generously offered to share their personal stories today. We will move into CRIS updates after that at 4 o'clock, and then dive into our first set of breakout discussions, hearing your feedback on the initial assessment at 4:20. We will take a 10-minute break at 5 o'clock and then reconvene, move into breakouts again to discuss the subcommittee high-level work plan. At 6:05, we'll do action items and next steps, and then move into public comment at 6:08. And members of the public during those breakout discussions will be, as we've done in past CRIS committee meetings, facilitating a discussion with you to get your feedback in the main room. Everything's being recorded today. You'll see recording at the top of your screen, and the breakout sessions will be recorded and posted to the website following the meeting. So, and of course, we'll adjourn at 6:30 and everyone can go off and enjoy their evenings. So now I would like to move to a very important agenda item, something that our CRIS committee members have asked for and welcomed, which is hearing personal stories from people who have experienced interaction with our crisis response system. So Liz, if you could stop the share, I'm going to turn it over to one of our steering committee members, Carrie Waterland, to introduce our speakers today.
Thank you, Jamie, and thank you, Vipasha and Representative Orwell. Tough to follow such beautiful words from both of you. Thank you. But I'm going to try, and I'm going to do just very brief introductions because I know we've got two people here today that are going to be sharing their touching, beautiful, heartwarming, tragic, and true stories. And I just wanted to remind all of us that this is an opportunity for us to realize that storytelling is how we connect. Storytelling is how we remind ourselves of the special quality that we have, which is humanness and ability to connect on a deeper level. And that is what this is all about, is reminding us that in all of our experiences, there is diversity of thought, diversity of experience, diversity of outcome, and all of these are valid in the conversation. Behavioral health and crisis response is, as Bipasha said, a topic that can sometimes create really tough conversations. And I am just thankful that two people today have stepped up to share their stories. So without any further hesitation on my part, I'd first like to introduce Jen Stuber. She is a member of our CRIS committee. She is a professor at the University of Washington. She's an advocate and she is a mom. She also lost her partner to suicide 10 years ago. And her experience, which she's going to share just a little bit of today, is a really big part of why she's dedicated so much of her energy to the 988 system and this CRIS work. So Dr. Stuber?
Thanks, Carrie. I really appreciate that introduction, and I appreciate being asked by you all to tell this story. And I just want to acknowledge that this is a story that I've been privileged to share many times, and but appreciate being offered the opportunity to share, because I do think there's things we can learn from it. Okay, so Matt Adler, he was a loyal friend, a father of my two kids who were 5 and 1 at the time that he died. He was a caring son to his aging parents and a corporate attorney who worked and lived in China and in the US. He was my best friend and my husband. And as Carrie said, he died by suicide 10 years ago on February 17th in 2011 at the age of 40 years old. He was deeply loved by his family, his friends, he loved his work, and he loved me. So the economic recession in 2019 really triggered a devastating episode of depression and anxiety for Matt. It really impacted his ability to engage with his wife, me, and his children, to focus at work. He couldn't, and even to read the newspaper. He withdrew from family, friends, and his work colleague. He's said to me, "Who wants a lawyer with a broken brain?" Matt was receiving treatment for his mental illness as he began to struggle. However, the mental health professionals he saw were not equipped to handle his hopelessness and despair, and then his plans for suicide. They did not follow through with best practices in caring for suicidal patients. They failed to notify me, his wife, of his plans to end his life, even though they knew of these plans. So there are a lot of amazing mental health professionals in this world and in this work, but we must ensure they are educated and supported by systems such as a functioning crisis system to tackle suicide, the leading risk of death for their patients. Matt was really not given a real chance to recover because of the failure of these professionals and of our crisis system. The crisis system was not a likely option for Matt, even though it was exactly what he needed at the time. Neither he nor I, and likely the mental health professionals treating him, knew much about the crisis system a decade ago when Matt needed it. That system, I'm sad to say, hasn't changed much since that time. Matt was having a mental health emergency that he was trying to keep hidden from others. It was so bad he went out and bought a firearm and developed a plan to kill himself. What lawyer who's been steeped in legal training about the criminal justice system would want to activate law enforcement to help or trigger a so-called investigation into whether he's competent to make his own treatment decisions? Since Matt's suicide, I have worked on numerous state laws and budget provisos in the state of Washington to help bring suicide prevention to the forefront of our state's consciousness and policies. I help champion the work we are all engaged in today. I am grateful for the receptivity I've received from so many legislators to tackle suicide as a public health crisis, especially Rep. Orwell, Senator Dingra, Rep. Chop, Rep. Callan, and Rep. Davis. I founded an organization called Forefront Suicide Prevention at the UW and moved on from directing its work this past year. I am now choosing to focus the next decade of my career at the UW on policy and systems work, such as the work on the CRIS and parent and youth focused suicide prevention projects at the UW Smart Center that I believe can have great impact on saving lives. I believe if parents and students knew what I now know about suicide, were oriented to prevention early on, were free to be vulnerable about their pain, learned ways to deal with it, and knew how to respond in the face of suicidal thinking, which is alarmingly common among youth today, we would save many young lives. As my kids are growing up now and are at higher risk for suicide because of their dad's suicide, this feels like the most important thing I can do in suicide prevention for my family and for my home state. The work of reforming our state's crisis system is vital and interrelated. Today, when I train parents and students about our current system to access help for suicide prevention supports when it's needed, they almost can't believe how complicated it is. I say to them, here's the crisis line number if you live in Benton, Franklin. And an hour away, here's the number if you live in Walla Walla. I recommend calling the National Suicide Prevention Lifeline first for concerns about suicide. A call center in the state will most likely answer and offer you best practices and try to offer help in connecting you beyond the phone call. But if you need help with an in-home evaluation or with involuntary treatment, they need to call the county crisis line number. Then I try not to take your person in crisis to an emergency department because there's really not much they can do for you there, but there aren't really any alternatives except for that, so you may need to. Your county may have a co-response team. Otherwise, if you need help and your loved one won't accept it, you may need to call the police. Talk to your school about what's going on, but they may or may not be able to help you depending on what counseling services they have available in the district. Furthermore, there isn't a great database on places where you can take your loved one in crisis or find out about available treatment that can help them to get back on their feet. So in other words, it's exhausting to even in a training to parents and teachers to describe how to get help for your suicidal person in Washington state. It's quite ridiculous even to talk about it actually. Imagine what it's like to live with this current reality if you were a person in crisis or their family member. So we're in this space together now to make a difference for others, to bring about radical reform. We need a vision of what we are working toward that is rooted in best practices, the full vision of an integrated system comprised of call centers, co-response teams, crisis receiving alternatives working in unison, responding to a single 988 number. We need to show our appreciation, support, and hear more from those who are doing crisis work on the front lines today. We need to be vulnerable and have challenging conversations with one another about what needs to change in order to get us there. Then we need to ask the legislature for what we need and advocate like hell for reform, unified behind our plan. If we don't seize this opportunity, each of us, we will have missed the opportunity of a lifetime to make change happen. I know there isn't a person here today who doesn't want to realize the vision of a person-centered, trauma-informed, integrated, compassionate, and accountable crisis system for all. Thank you for your time today.
Jen, thank you for your bravery. I hope to be as brave as you one day to share my personal experiences. You honor us, and thank you for also ending with a true and real call that's in your heart and a call to action for all of us on this call. So thank you. And with that, this is why we are here today, everyone. And with that, I would love to also introduce Michael Robertson, who, Michael is a name that I've seen around for a long time, and I'm very excited for him to share his story. He is also a member of our CRIS committee. Thank you, Michael. He works for Peer Washington's Kent chapter as a peer services specialist for King County Drug Diversion Court, and he volunteers for a number of organizations, which is where I've heard Michael's name. He is going to share his personal story with substance use disorder and interactions with law enforcement. And Michael, with that, I would like to give the time to you, please.
Thank you so much for the kind introduction, Carrie. And I'm Michael Robertson, a person who is surviving and thriving within the recovery from substance use disorder. I'm a constituent of the 43rd and Mr. Chop. And so it's important that I share my story. And thank you so much, Jennifer. How we get to a point to where we can differentiate between crisis and criminality. And that's why it is important for me to share my story, although it doesn't directly, it deals more with behavioral health than it does actual crisis, because of my experience in dealing with law enforcement. So thank you for the opportunity to share with you my victory and how I got here. I'm a person who certainly can and does identify with substance use disorder, and I will continue to unashamedly do so. Despite the stigma, I fought through this disorder in the height of the war on drugs and came out the other side against steep odds. In my youth, I used it as a matter of course and segue into adulthood. There were no initial adverse effects, in my own opinion, at the beginning, and the lack of control was undetectable even to me, even though others began to see it in my adolescence. My sense of entitlement from my upbringing, I believe, hampered my ability to equate my lack of esteem and inner turmoil with my obsession to use. What I didn't know at the time is I was using substances to mask abandonment, sexual abuse, and cultural identity, and even some suicidal ideation issues as well. Most of that stemmed from my being adopted and not having any way to identify self-discovery, develop autonomy, or have my esteem sanctioned by my cultural peers. The bottom line is, for as long as I can remember, I never felt wanted, included, valued, or a part of the community. My use propelled me into a way of life of self-destruction emotionally, physically, and spiritually. I had an insatiable need for isolation, and because of the shame of constant failure in the pursuit of perfection, I thought my disorder had to do with failed resolve and something inherently wrong with me morally. I could not stop using until I was sent to prison, and when the confinement was lifted, I would use again. This cycle of use, arrest, confinement, failed convictions of abstinence, and even worse, use continued for over 25 years. This cycle was bolstered by housing insecurity, criminalization of my disease by clinical, judiciary, and societal approaches, and society's view in general of substance use disorder at that time. Not only was I in this cycle of addiction, I was involved in a society that refused to identify it as a disorder. I was constantly told through different entities that if I stopped victimizing the public by my behavior, I would stop using drugs. I sought out solutions that would stop me from using, going to prison, housing insecurity, and put me in good graces with my family. It wasn't until the present opioid epidemic caught momentum and I was arrested the last time that my life changed. I, of course, had no problem with structure and commitment, so I was offered a chance to be in drug court in lieu of confinement and engage in treatment, and I took that chance. I noticed compared to my arrest for drugs in 96, 99, and 2001, and treatment inside a prison and on parole, that the attitude from others and from myself was different. Treatment now didn't talk about stopping my criminal behavior. They asked me about my trauma for the very first time and provided a process to work out for the root of my pain and my need to use drugs and alcohol to attempt to repair past and present danger. I even noticed they used different terminology for much of the same treatment processes that they had before. For the first time, I didn't feel like I was begging for a chance at changing my life because I was suffering from a disorder instead of going to prison. Treatment came first, not confinement. I was able to get inside some spiritual approaches to my disorder that fit me. There was certainly a lot less stigma, and I didn't feel like I was singled out by clinicians, society, or the judicial system. I was fully able to grab the opportunity for a new life. I'll close with this. I'm only speaking to you because the reality is that many persons whom I never met had to overdose, die in crisis for me to have a chance at real recovery from a disorder that had my name on it, along with many others who aren't with us today. Their sacrifice removed much, but not all the criminality and stigma for what was venomously called addiction and seen solely as criminal activity. Those loss created space for my healing. I didn't do any of this alone. I received help from the community. Please remember that the community is the most critical part of the healing environment because it produces trust, empathy, accountability, commitment, and tolerance for not only of the lived experience, but those that weren't able to live as they experienced as well. And so I just, as I said earlier, I just truly believe that we can begin to draw the line between criminality and crisis. Where are we, and where are spaces that each of you, because I don't see through many of the committees that I serve on, much of the volunteering I do, whether it's behavioral health, whether it's crisis work, whether it is peer advocacy work, I don't see many faces that look like mine. And so in the advent of such a pendulum swinging within governmental constructs, we should say, someone my age and with my experience without your help can come across as very disgruntled and maybe not being heard the right way, even though you all are going to present the same information, right? So it is important that I share with you my experience so that you know that there's some proof positive and there's some evidence that can support the very changes that you are making that are indeed and not in theory, right? We can do better than how I got here, and I'm sitting in front of you. That was great. A nice little step, drug court, diversion program. But what I just believe that we can do even better. We're not even halfway there. So it's easy to say we're trauma informed, but are we trauma informed, or are we just trauma aware? We need to have a distinct difference and have a knowledge of both of those things. Being trauma aware is just standing there at the accident saying he looks hurt. Being trauma informed and trauma active means I'm going in there and I'm helping somebody. I'm Michael, and thank you so much for letting me share my story. And thank you all for being here.
Michael, thank you so much. I think that you lending your voice to those who don't have the ability to speak on their own behalf and to help elevate voices up. You're doing that, and I'm just honored by you living that recovery is individualized and personal, and it's about you. And so thank you for, I think, telling your story, but also helping us remember community, connection, recovery. All of those things are absolutely necessary. And thank you for challenging us, because Michael, there are times that I am trauma informed, not trauma aware. There are times when I am trauma aware and not trauma informed. And you're right, we can and we must do better. So thank you for that. And I'm glad that you spoke today. And Jen, thank you again for sharing your voice and your story, both of you. We couldn't do this without you, and just honored that you're part of the committee. Thank you. Jamie?
Jen, Michael, thank you so much for setting our stage today, for setting our table with your stories, and Carrie for the beautiful introductions and acknowledgement. One just last point on this, which is our stories to date have been primarily from our CRIS committee members and some staff. We would very much like to open this opportunity to members of our community. So I had hoped to have more to share with you about the plans for that today. This is still a little bit of a journey and a work in progress. So my expectation is that soon we'll have more information to share with you about how we will start bringing community member stories to this space at future CRIS committee meetings. But thank you again for this time. It really is a powerful way to start our meeting, an important way to start our meetings. I'd like to move now to some updates from Michelle Roberts at Department of Health and Carrie Waterland again at Healthcare Authority, who have some updates on a lot of the work that has been happening essentially behind the scenes. We have gotten feedback from CRIS committee members that would be helpful to know more about what's happening, that it feels like between these meetings that maybe not, it feels a little bit stalled when you don't know what's happening behind the scenes. So the intent today is to have this standing agenda item to catch you up at our CRIS committee meetings as to what is happening. So why don't I'll turn it over to Michelle Roberts first with Department of Health, who's going to offer some updates. Michelle?
Well, good afternoon, everybody. Thanks so much, Jen and Michael, for sharing your stories. You're a powerful act to follow, especially that I've just got some tactical updates to share today, but just appreciate all the good points you've given us to think about. So for those who don't know me, Michelle Roberts, I am the Acting Assistant Secretary for our Prevention and Community Health Division at the Washington State Department of Health. That is the area of the department that houses our suicide and injury prevention work. In addition to, part of that work is supporting the 3 national suicide prevention lifelines, which will become the 988 call centers in our state. So, which is step 1 of all the work we are here to do together. So I have a couple updates today on some of the work we're doing in the movement towards the implementation of the 988 number in July of this year. So I'm going to talk about where we're at with some funding updates to how we're working with the call centers to support the work. So first of all, we've had a number of questions about the additional funding that is going to the 3 call centers in our state. And we have figured out the funding allocation for the call centers to build capacity. They obviously need more resources to be able to be ready for July. So the funding allocation is we've used kind of a base and plus additional funding. So the base for all 3 call centers was established because we know each call center has expenses related to increasing capacity. And the plus part of the component of the allocation was calculated based on previous call data for each of the call centers. And then the national administrator who's Vibrance modeling for cost per contact at a moderate volume rate. So we are communicating the amount of each of the contract amendments to each call center, and we're working on getting that funding fully into contract and get those amendments processed. Over time, we know we're going to need to really continue to assess evolving needs, how funding is being utilized, better understanding call volume from having a 1-point entry into the system, some of the other work that's coming under the full work of this committee and House Bill 1477. So more to come as we address ongoing what the right funding allocation is and what call volume will continue to, how that will evolve over time. So that's one piece. The second piece I wanted to share was about a grant that we have applied for as of yesterday evening. So SAMHSA is the federal agency that supports the National Suicide Prevention Lifelines and is the one who's charged with implementing the federal legislation around implementing the 988 number. So the SAMHSA has announced a new grant opportunity to help states be ready for implementation of the 988 number. It was a very quick turnaround. About a month ago, we got the notice of funding opportunity for states and territories, and it's really about building capacity to implement 988. One application per state will be funded. So we submitted on behalf of the state from the department. It was submitted yesterday, like I said. The funding opportunity defined the maximum amount of funding for each state or territory could apply for, based on, again, a base model and call volume. The maximum award that Washington could apply for was $2.6 million. We applied for that a full amount. It's a 2-year grant, and there's a requirement that 85% of the grant award is passed through to the call centers. So our funding formula for the grant dollars is based on the same base plus model we talked about earlier. And we're expecting to find out about the award by April 15th. We anticipate this is not a competitive award. The money is there for us. And hopefully we'll have a start date by hopefully right about April 30th. So to do this, to decide what we were going to cover within the funding opportunities, we met with the leadership of each of the 3 call centers and our colleagues at Healthcare Authority and identified kind of the direction for the scope of the work. The focus of the funding was an opportunity to improve state and territorial response to 988 contacts, including calls, chats, and text that are coming in our state by 1, working on workforce issues, including recruiting, hiring, and training workforce staff for the call centers. In second purpose of the funding was to engage the call centers to identify, to unify 988 response across states and territories. And lastly, to expand the crisis center staffing and response structure needed for successful implementation. Historically, the National Suicide Prevention Lifeline call centers have not been funded at a level necessary to ensure they could implement follow-up services, which is part of the standards for National Suicide Prevention Lifeline call centers. And the funding models we've been using so far and have gotten from our national partners have really not taken follow-up services into account. And that's also an important piece of, as we know, of the 1477 legislation. So we learned that this funding opportunity can help us start to build models around follow-up and build up the follow-up program development. And so we decided to use this funding to help support that scope of work, to help as a state better meet this national standards that are set, and to help set the groundwork for some of the work we need to do together for 1477 in this CRIS committee. So specifically, to get down to the bottom line, our application is focusing on development follow-up program and staffing, which includes capacity building and training for peers, as well as capacity to develop a student intern program. So that's going to help us get at a workforce pipeline. These efforts will also support work to improve behavioral health provider development and preparing a workforce that can be called upon to staff the call centers, and especially help us adjust staffing when we have spikes in call volume throughout different times of the year. So we could shift for initial contact or shift staff back to follow-up. So working on building out that model. So those are the couple high-level updates I have right now, and happy to take any questions. I don't know, Jamie, if you want questions now or if we're going to have Carrie go first.
We can pause for a moment and take a couple questions, Michelle, because I'm worried if we go straight to Carrie, then we might have so much that people will forget their questions. So CRIS committee members, any clarifying questions for Michelle about what she just shared? Use your raise your hand function if you have a question. You may also send me a chat. Representative Orwell.
Thank you. And thank you for that presentation, Michelle. Great work. I'm curious with the federal dollars, if they're any thoughts of the use or recommendations they're making around extending the text functions, text and chats, or is that something they're looking for us to do at the state?
You know, there's a lot of work we still need to do in that area. I think some of this work under the SAMHSA grant will probably bleed into that, but we're really, there's still a lot to learn, and it's not a primary focus of the grant application for everybody. We're thinking about how do we ensure some initial level of tech support in the state. One of our call centers has been doing that kind of well, they could speak more to it, Volunteers for America, but some limited fashion in supporting some national outreach around text. And so I think we're thinking about how do we continue to support that and then continue to support more build out of that work. But it is going to take time to develop it. And we are, believe it or not, with a lot to do, we are way ahead of other states in this area, but thinking about an initial kind of plan to support that come July 1, and then working with the call centers to continue to build that out over time.
All right, Dylan.
Thank you. And I do agree with the necessity and importance of having multiple avenues to be able to connect with crisis responders, especially with the tech support. The question I had was around the follow-up scope in terms of, is the follow-up, is that going to be dedicated staff at these crisis hubs? Or are we talking about follow-up for outpatient mental health services, for example?
Yeah, right now we're talking about a more limited scope of follow-up, really about if somebody calls a 988 call center, that we could do a follow-up contact with those people. And there is some level of, well, there is requirements at the national level for Lifeline call centers to do follow-up, but it's really never been funded, and we've not done as much as we could. So talking with the call centers, we want to build that out more, and hopefully it will be lay the groundwork. In 1477 and the work we have to do together for CRIS, there is a lot more work around follow-up, crisis service support for follow-up that I'm hoping, well, I think we're hoping, and when we talk with the call centers and healthcare authority, that's starting to build out this part of the plan and building some capacity for this initial type of just checking in back in with people will help lay some groundwork of the work we need to do together as CRIS for a more comprehensive follow-up.
All right, thank you. And that also just brings to mind some of the other work that is going in with these like health information exchange hubs as well for generating some of these referrals. So perhaps someone is going through a crisis that might be based off like rental assistance concerns or something. And I know there's various pockets of folks that are talking about bringing together these various hubs, and I'm that just a whole nother thing, but very much connected in terms of being able to provide comprehensive supports for our state.
Thanks, Dylan.
Yep, I was going to say we agree, and I think that's an important place for later on today as we keep working, building out the work plan, that we need to make sure that's caught. And I don't know if Carrie may say a little bit more about that, especially the CIE work the state's doing.
And I'm just going to remind CRIS committee members, if you don't mind, before you speak, if you could just refresh everyone's memory about your organization and your role on the committee, and that'll help reorient people to who's sitting on our committee. Darcy.
Hi, Darcy Jeffy from the Washington State Hospital Association. Michelle, I just have a couple technical questions about the grant. You said the award you probably hear about it about April 15th. Is there a implementation time that you need to get started once you hear about the award? And then is this a use it or lose it grant? And if so, do you have to use all the money before the 2 years? I know SAMHSA sometimes requires that, or you have to pay some of it back.
Yeah, on your second question, I don't know. It is a 2-year grant, and I don't know what the options are for carry forward or anything after that. But I'm hoping, since the whole system has costed out at much more than $2 million to support it, that I think we will have no problem in using the $2 million over 2 years. But we can follow up if you want to know the options, Darcy, about carry forward. And your first question again was about, implementation timeline, is that correct? So we don't have a hard date from the feds about when. We're hoping that we would know by April 15th, and that The official award would be here by April 30th, and we want to turn around and get that moving because all of the CAR centers and all of us have a lot of work to do for that July 16th 988 implementation date. So want to get things going as quickly as we can.
Great, thank you.
All right, thanks, Michelle. I'm going to move on to Carrie with some updates from HCA.
Perfect. Well, Michelle did a lot of talking, and of course, as soon as I go off mute, my dog always likes to say hi to everybody. So I apologize if you're going to hear that. He's a big fan of SAMHSA money as well, apparently. So we're gonna do a lot of talking about SAMHSA again from our point of view. So thanks, Michelle, for getting us started. Behavioral health is really funded to a large extent by a couple different avenues, by the really great gifts that our state legislature gives us in the form of general fund state. They also grant us expenditure authority for the funds that come to us through the federal government. And that's where SAMHSA comes into play for us. That's where those things that you may hear the behavioral health system talking about block grants. And those of you that work in the block grant funding arena, you know how fun that can be. But the mental health block grant does have a 5% set aside right now for crisis work. We are waiting to see what that may be, if there are any increases that are kind of recognized by the federal government once the federal budget is passed. We don't know yet. Washington State traditionally has gone above and beyond what the federal percentage set aside has been deemed for a lot of these set aside buckets. And so I see that that there are further opportunities for us to have that conversation, kind of regardless of where that federal funding lands. Wanted to share again in the theme of SAMHSA that Healthcare Authority applied for and received 2 Transform Transfer Initiative grants, TTI. I'm going to say that because it's easier from here on out. But these were 2 awards that were received for special populations, our AIAN population for crisis, and then children and adolescents. And these are really aimed at enhancing mobile crisis response work and various startup activities that support 988 proper. In these kind of transformation grants, Washington will develop an electronic resource guide for the Indian Behavioral Health Hub that Department of Health has been really instrumental in leaning in on and helping to develop with all of the partners who are developing the Indian Behavioral Health Hub. Thank you. Tribal 988 line as well as non-tribal 988 lines statewide. So those electronic resource guides will be developed. There's going to be development of a training curricula for all 988 staff focused on providing culturally humble care to AIAN populations, really focusing on mobile response stabilization services, MRSS, kind of creating a quality learning collaborative to inform the program, to inform data collection, and really to foster national collaboration. That is really a youth-focused mobile crisis response program. And then lastly is really focusing on developing models to pilot interventions at 2 interruption points. One is emergency department visits, which we know this group, the CRIS committee, has really wanted to lean in on. And then the other is foster care transitions. And both of those are really looked at the goal of reducing the strain on the transitions and the trauma and impact that can happen at those transition points. So those are the TTI grants that came out of SAMHSA that are really focused on, again, the 988 work. New funding is being made available for the implementation of 988 and mobile crisis teams. That's part of the ARPA funding package that's being made available through CMS. We do have provisional approval from CMS, our federal partners, and we've got provisional approval around our recognition of adult and youth mobile crisis teams, really looking at how we can increase local behavioral health mobile crisis response team capacity and ensuring that each region has at least 1 child and 1 adult, 1 child and 1 1 adult and 1 child and youth, 2 things. That was a really tough thing for me to say, that are able to respond to calls coming from the 988 crisis line. The state really is going to ensure that a minimum of 6 new children and youth crisis teams get put online quickly. And again, that's part of a provisional plan that we're waiting for CMS to come back and let us know if they have given us full blessing on that plan. Wanted to talk a little bit about the FMAP, Federal Medical Assistance Percentage, that match map that can come with it. So FMAP, looking at mobile crisis teams and enhancement funds that are available, we in HCA have gotten a lot of folks from the community who are involved in crisis work asking, what does this look like for enhanced FMAP and what is the state going to be doing, right? I see some nods from Representative Orwell and team. So here are a couple updates. The funding will be available to be used from April 1 of 2022 until March 31st of 2027. If folks want any of this stuff in writing, we can also kind of talk offline and talk about how we can provide that to people, because I know I'm just talking a little bit today. FMAP will be at either an 1815 for 3 years or a 90-10 for newly eligible, whichever is greater, depending on where you're at with your mobile crisis team. The mobile crisis response teams will have to meet a definition that's established by CMS. Some of the things that are included in that, I'm going to spare you from all of them, but some of the things that are included in that is that the team will be available on a 24/7 basis and able to do outreach in community settings. I know that's an important one to an awful lot of people on this phone call. Teams also have to be composed of at least a mental health professional, a substance use disorder professional, and a peer support in that pairing. Training on trauma-informed approach, given what we've talked about today. Training on harm reduction and training on de-escalation will be needed as part of this FMAP enhancement. And we know that there are some things about the training that there is an availability of a firehouse or a capacity model for mobile crisis teams, but we're waiting for complete guidance from CMS on that. And so more to come on that. We also will partner with the BHASOs, the Behavioral Health Administrative Service Organizations, and the MCOs. To really work, and local providers, on how to really ensure that we meet the CMS rules to allow us to receive the enhanced funding. So that's going to be something we're going to be working with a lot of people on. Really thinking that as soon as training is complete and approvals are received from CMS, we are going to be trying to apply for that new FMAP as soon as possible. So working on getting everything going quickly. And then the last update that I have, Representative Orwell, I think that some of this might be useful given some of the IT questions that you just asked. There is an IT implementation enhanced FMAP as well that really looks at telehealth services. It gives a 90-10 admin tech cost. So telehealth services, developing and implementing software applications to facilitate communication between crisis call centers and mobile crisis providers, implementing text and chat technologies that may and should include youth, and then implementing and supporting the use of data sharing and tracking software. This funding is on that same timeline around the April 1, 2022 to March of 2027. And we plan to take advantage of that FMAP enhancement when the 988 tech systems are ready for us to have those conversations of how we can link those things up. So that is, that's an update on an awful lot of SAMHSA money and federal interaction, I think, as well. So just piggybacking off of what Michelle shared. Happy to take any questions.
Thank you for the very thorough update, Carrie. It's awesome.
Sorry.
No, it's great. I think this group is craving it, so I'm really pleased. We are running a little tiny bit behind schedule, but I think I can buy time elsewhere. We actually only have 7 people signed up for public comment today, so we have a little bit of extra time. But I do want to remind folks, the questions right now are coming from just CRIS committee members, so members of the public. If you have a question, feel free to send it to me in the chat, and I will refer them to our wonderful staff, and we'll do our best to answer them or put them in FAQs. But right now, any CRIS committee members have questions for Carrie and the update she provided? All right. If you think of any questions later, which is something I often do, please do pass them along to us, and we will get them answered. All right, so actually we're not so far behind schedule then. Let's move into our first breakout discussion group. Just a reminder, so this first breakout discussion group, our objective here is to gather your feedback on that initial assessment. So we know you've already had an opportunity to review, well, I'll back up. You actually reviewed the key themes at the November meeting and provided feedback. Then you had an opportunity to review the actual initial assessment and provide your feedback, as did members of the community. What we want to focus on today is getting your feedback on what gaps we need to fill when we do the next iteration. And I'm actually going to ask Representative Orwell to take a few minutes to set the context, and then we'll move into our breakout sessions. Representative Orwell?
Thank you, Jamie. And if I mind, do you mind if I say just a couple words about the legislative session before I jump into this, just around behavioral health and 988? I think the good news is that the legislature continues to really prioritize behavioral health, and there's a lot of members working on this. And I guess a couple things I would let you know is we are looking at really creative investments around behavioral health, and we're looking at the rates. And I really want to do a shout out to Representative Lauren Davis, who's doing a lot of work around peers. I think that's one part that our state's really behind, is the peer workforce. And so we're trying to move some of those forward. So the one thing that is concerning is there was a Senate bill introduced, Senate Bill 5816, which would actually eliminate the fee that we put in place last year. And we're hoping that does not move forward. It replaces it one time with state dollars, and we know to really change our system needs dedicated dollars. And that this really is the source that lines up. It's the source we use for 911 and should be for 988. So again, we hope that does not move forward, because we feel like we're ahead as far as states, and that these investments need to be stable and ongoing to support our call centers and the other work. So that's my little update. I don't know, Senator Dinkra, if you're on, if you want to say anything about the session. I thought I saw her name.
I think we have a staff person from Senator Dingra's office taking notes.
Okay,
too.
so I really, Jen and Michael, thank you for sharing your stories. And I'm so sorry the system failed you. And I appreciate your courage and your strength, because this process, I don't think we can move forward with the conversations we're going to have today and understand how the system's broken and how to fix it without your feedback. And so I know I want to thank the initial assessment that came out, and that was just a starting point for this conversation. And all of you have expertise you bring to this process. Again, we want to understand where are the gaps in the system. And that's going to be key to really creating a system. And we keep saying trauma informed, but responsive, and a system that is really going to work and be really community based. We already know, and I want to thank you for the feedback we've already received. I think it's excellent. We already know that there were gaps in the report. Our friends from 911 and our EMS friends and hospitals, we know we have a lot more feedback we need around children and adolescents, especially LGBTQ plus and BIPOC communities. So we just want you to know that this is our starting point, that this is our time to really roll up our sleeves to understand how the system's broken and really the vision. And I love the visions that have been shared today of how we move forward. So again, thank you, and look forward to hearing from all of you.
All right, so our next step is we're going to move you into, we're going to move CRIS committee members into 4 facilitated breakout groups. There'll be a staff person in each room to both record the discussion and facilitate the discussion. And then I'm going to ask community members to stay in the main room here with me. And we're going to have a discussion about get your feedback on the vision to inform the vision discussions that'll be happening. So with that, we're going to spend 20 minutes in our room, and then we're going to reconvene here at 10 minutes to the hour to do a debrief, to hear what you talked about in your rooms. And then we'll move into our break. So with that, Brittany, if you would be willing to send everyone to their rooms. Okay, we'll give our community members a few minutes to, I'm sorry, our CRIS committee members a few minutes to move into their rooms, and then we'll get started. So community members who are here, if you'd like to participate in the discussion and would like to turn on your camera now, please feel free. Julie, thanks for leading the charge there. All right. Wonderful. I'm so glad people are ready to engage with me. Of course, if you prefer, as ever, if you prefer to communicate in written form, please feel free to use the chat if you have any feedback, and I will do my best to pause and take a look at the chat every few minutes. As you may have heard from Representative Orwell, we got feedback that in the initial assessment that it would be really helpful to have a clear vision for this crisis response and permit for our system. And so as a result, in response to that, we are convening an ad hoc committee to begin to really address that vision and advise the steering committee on what that vision should look like. So my question for you today is, as you think about a vision for our crisis response system, what would you like to see included in that? What would you like me to pass along to that vision ad hoc committee as they start thinking about shaping this vision? And please use your raise the hand function if you'd like to speak. I'm going to check the chat because I see a couple of, oh, Julie, actually, you are not on the CRIS. I think you might be on a subcommittee. You are here as a member of the public today, and I'm grateful you're staying with me. And then let's see. Oh, Nelson, your camera won't go on. That's okay. Feel free to raise your hand anyway, even if your camera is not cooperating with you today. All right, let's start with Laura. Laura, what would you like us to pass along to this ad hoc group? I think you're on mute, Laura.
I was just double checking that I was allowed. No, really, I didn't know whether I could speak or not.
Oh, yes, I'm sorry, yes. So
okay.
right now, it's very confusing, I understand.
It's been a long day.
Right now, it's a conversation with community members.
I think what I would like to pass on really is that, and I brought it up in a whole different meeting about law and policing today, a conference that's going on. And I think the whole issue is that crisis doesn't have to be the end, that it could actually be the beginning. And so often, you know, we dust people off and say, okay, we've got that handled, and push into a mental health center or some kind of treatment program and go on, when in fact, you know, it could be the beginning of recovery. It could also be the beginning of, you know, really good treatment that includes alternative services, not just traditional services. So I just want to raise that issue of the pathway of crisis doesn't always have to be, you know, pushed somewhere, you know, against something, but that it be more of an opening towards something brighter.
I like the way you framed that, Laura. It sounds like you'd like the vision actually to be looking for that better future and the steps beyond that first crisis intervention. Am I hearing that right?
Yes.
Okay, very nice.
Yeah.
Thank you for that.
You're welcome.
Other contributions? Does anyone want to build on what Laura offered or have a different perspective on what you'd like to see included in the vision?
This is Nelson. I just had one quick comment kind of tagging on that. So many years ago, we were in crisis with one of our children, and we had to have the police at our house more times than I care to count. And one time has always stood out to me, and it illustrates the severe need of training and coordination. We had our child who climbed up on the roof of our garage and was throwing bottles at people. The responding officer, I later found out, had taken training all on his own on how to respond to a crisis like that with juveniles. He went on his own and learned about our children's crisis system in Pierce County. And he was directly responsible for connecting us to wraparound services and other supports that ended up getting our family on a road to recovery. He did all of that on his own. I'd like to see that level of training and coordination mandated.
Nelson, that is such a great story. Thank you for sharing that with us, the luck that you encounter someone with that training. And I will make note that that is something important for you to see, that kind of training in the vision. We have a couple hands up. So Joe, and then actually Joe R, followed by Joe V. So Joe R.
Good afternoon. A couple things that actually are my concern and hopefully will be incorporated into the vision and ultimately system operations. One is that it's a unified system, so it's actually cohesive, and systems have a tendency to develop fiefdoms and one-offs, and we cannot afford that in a crisis system. And with that comes a system of care that's, as was mentioned by the previous person, as coordinated. So that's something that's going to actually have an intersecting across the state as well as the region as well as the community. And then the second part is like I'm sure you've heard 100 times over, is no wrong door. So access has to be able to be across, whether I'm an outpatient therapist or I'm a primary care doctor, or I am a parent, or I'm a teacher, wherever I may be, that I can get access to the same level of support, services, intervention, and all those pieces that go with it. But again, my biggest piece goes back down to really the unified, coordinated piece. That's going to be, this is a huge, huge undertaking, in my opinion. I'm extremely nervous about the timing of how fast this is coming up on us. And there's a huge amount of, it's definitely a huge load to push. I know you got fantastic people representing us and moving this forward, which I'm grateful for. And so I conclude by saying thanks for all the work.
Thank you, Joe. So I heard a lot about that coordination and unified piece. Thank you for raising that. And the no wrong door is really important. We'll make sure those get passed along to our vision ad hoc committee. I'm going to take Joe Valentine, and then I want to read a chat I got, and then we'll go with Melanie. Joe?
Thank you. I got 3 points I want to make. First, well, the initial assessment was a great document. And one of the things that it portrayed is the chaotic and fragmented nature of funding crisis services. As somebody that has to figure out how to braid all those funds together, I'm at the mercy of independent business decisions by 5 different managed care organizations who change their decisions every 6 months. So I guess part of my vision is to really have a coordinated approach where the state takes back the responsibility for how it uses Medicaid dollars and doesn't abdicate it to the MCOs. A second point is, when I look in the North Sound about where we need to expand crisis services, it's really in the direction of co-response with law enforcement and EMS. That's where the opportunity is, really, to get to folks earlier and earlier. But that requires me to kind of get out of the box in how those programs are structured. And we try to come up with different ways of funding them because Medicaid doesn't fit very well. But I'd like to see that recognized in the vision that we have partners out there on the ground in law enforcement, EMS. They really have to be part of the solution. And the third point is, I really liked how you had folks tell their stories. And it made me realize I have to do a better job of figuring out how can we listen to the stories of people that have actually used crisis services, particularly communities of color. We just haven't done a good job at that. So I'm hoping as we construct the vision that there is an opportunity to really weave those voices in there. And thanks for the opportunity to comment.
Thank you so much, Joe. I think you make a really important point about having this all be informed by community voices, and of course the particular point about people of color. And you're right, we have not done a good job to date of getting those voices to the table. So thank you for raising that. I'm going to pause for just a moment. I'm going to pause, and I'm going to remind folks, if you could please use the raise your hand button, that'll just help us keep from talking over each other. Melanie, just one moment. I'm just going to read a comment I got in the chat, and then I'll come to you. I got a comment in the chat asking what is needed question. Of course, resources for those who call, a warm environment to calm down and receive hope, a map that people can see for concrete help steps. This is what Pamela would like to see in the vision. I also saw another comment here, agreement with Joe Valentine that the system needs to be fully funded and not require bake sales or golf tournaments to fund it. Great point, Joe. All right, Melanie.
Everyone, glad to be here. My name is Melanie. I am intern with Rep. Orwell's office from the University of Washington's School of Social Work. The main reason I wanted to intern with her was to do some work on 988. I live with serious mental illness and have experienced a lot of trauma within the crisis system in Washington State, particularly in King County and Whatcom County. And one of my biggest concerns right now is that peers are not being included enough in this process. I really, really think that those of us that have experienced how traumatic and how long lasting the trauma is of the crisis system, we need to be the ones to say, here's what didn't work and here's what would have been so much better, because we know what would have been so much better. We know exactly what needs to happen. So yes, service providers and folks at the system level obviously are so crucial, but it needs to be led by folks that we're doing this for. It needs to be led by folks that are going to be utilizing these services. I really loved what, I can't remember the gentleman, but he said, in terms of all the fragmentation in the system, braiding it together. When I had my last episode, if anyone had taken the time to look at my chart, I was going into emergency departments sometimes twice a week trying to get support. Braiding that together to have everyone on the same page to help people is just so important. The last thing I'll say, which kind of ties in with what Jen was talking about, I think oftentimes when folks think about mental illness, it's easy to think about people who are houseless, who are addicted and living on the streets, but there are folks with mental illness in every neighborhood, every racial and ethnic community, every economic spectrum, and everyone needs support. I oftentimes wasn't able to get the support I needed because I was doing too well and had too many resources. I had a family that would support me, but they didn't know how to help me. They're not mental health providers. So we need to make sure that the public understands this is for everyone. This isn't just for, folks that are really struggling in the homelessness system. This could be you. This might be you. And I think that will really help folks get on board with, the tax that's going to be put on. And so, yeah, just that in the marketing piece, I think would be really helpful. So thank you for letting me speak.
Thank you, Melanie, and thank you for your work on this. I want to highlight a couple of things that you said that I think are really important. So Joe Valentine talked about the fragmented funding systems and the difficulty, the challenges with braiding those together. And Melanie, it sounds like you were highlighting that same pattern replicated itself in terms of like sharing information and coordinating care in your personal experience. And the other piece that I just wanted to highlight is what you just told about this being for everyone is yet another reason why these personal stories and hearing the diversity of stories of people's experiences are so very important, because I think they really are dispelling some of them, certainly misconceptions that I carried before I started doing this work with you about what the mental health and crisis, who the mental health and crisis response or behavioral health and crisis response system is for. So thank you for that. We'll take another quick look at the chat here. Let's see. We have one from Sylvia. Excellent point about fragmented funding and MCOs. Great comments by Joe V related to co-responders with the acuity of the crisis. Mental health professionals cannot do this alone. Lastly, are we looking at crisis prevention versus crisis response? We rely too heavily on crisis response with little accountability on prevention. So thank you for that, Sylvia. Bonnie. Oh, Bonnie, I think you're still muted there. There we go.
Okay, I worked in inpatient psychiatry for 37 years at University of Washington Medical Center as a nurse. And I felt very confident on the kind of care that we provided a lot of crisis, care to those that were, at the brink of going to kill themselves, or maybe they had made an attempt. But I always felt like oftentimes that we were sending people out without the kind of care that they needed, because the kind of things that they needed just didn't exist. One-to-one therapy is very good, and people being followed for meds is, obviously that's needed. But I do like the idea of peer support and just having, somebody there who understands the basics. The other thing I wonder about is, could people, it seems like mental health services are often delivered by people that have masters and doctorate and, higher degrees. Yet we've got a lot of people that have, graduated with bachelors in psychology, bachelors in social work. I've seen those people be utilized in mental health centers, providing a lot of skills, coping skills training for people. And I just wonder if we could expand peer support and use a lower level, of people that are skilled and have knowledge. It would provide two benefits. One, oftentimes people that have bachelor's levels can't, in psychology and social work, they can't work in the field, and they, maybe they don't have the money to go get a graduate degree. And so they tend to go into other fields. Why not utilize them? And I think that that could be very helpful to people that are coming out from crisis, but also for people, maybe, those people could be used in the crisis response too. I've seen, people with bachelor's levels work very well, particularly at Harborview in the DBT program. And, I could see that being really useful and providing a whole other level of services.
I think that's a very intriguing idea, Bonnie. And in fact, that could also, a third benefit might be that it could really address some of the workforce issues that the system is facing, that I've heard a lot of you mention in past comments. But I have heard today a common theme that I think could be raised in the vision about the importance of peers in this journey and this process. So thank you for raising that. I'll note too that a lot of the detail that you're offering, all of you, also I think will be useful for subcommittees to hear. And I know a number of you are participating on subcommittees, so I imagine you'll have an opportunity to revisit this conversation. We have about 3 minutes left before all of the CRIS committee members come back. I'd like to just take a quick look at the chat here and catch all of you up. Let's see. Joe R. offered, the crisis system needs to be integrated with services across the whole system of care, including primary care, behavioral health, substance use disorders, law enforcement, hospitals, schools, private practices, clubhouses, and so on. And cultural sensitivity is also critical. I think that's, yes, and I think that is definitely key to this vision from what I'm hearing. I heard from Pamela, I would like to emphasize Joe Valentine's plea for Washington State to take back the authority and the mandated care systems from for-profit managed care organizations. And then I got a note from Jim Bloss here, first of all, supporting anything that my friend Joe Valentine recommends, but second, offering regarding mobile crisis support teams. Not sure what the HCA and the CRIS group is planning, but the CAHOOTS model being used in Oregon is already a proven evidence-based way to perform this absolutely necessary service. Gonna close my chat there. Looks like we're just about out of time, so I probably can't take any more comments, but please do, if there are other thoughts that you have that you'd like to pass along to the ad hoc vision group, please do use, in fact, I'll pull up the email address for you to remind everyone of where to send any comments that you'd like to have go back to the steering committee and the CRIS committee. If you think of other things that you'd like to see addressed in the vision or potentially addressed by the subcommittee. So let me send this around. Email address that I just put up there is the one that you can use. Check the chat again. I've got a couple more here while we're waiting for folks to come back that I will read to you. Harborview Psychiatric Emergency Room nurses yelled in my face inches from my eyes when I had paralysis from pseudo-Parkinson's syndrome, now known from depleted dopamine as the day progresses in persons with traumatic brain injury, such as myself. This was thought to deter me from so-called aberrant behavior, which was from instead the neurological damage. I had no ability. The DB program began my suicide start because they would not address my needs, but only talked about suicide. All right, looks like we have our CRIS committee back. Thank you, community members, for spending some time with me. I really appreciate it. If community members, if you wouldn't mind turning off your video cameras now, that will allow me to check in with our CRIS committee members about the conversations you were having in your breakout rooms. We're going to debrief. We're going to by about 5 minutes because we were running about 5 minutes behind when we started these. So we'll debrief for the next 10 to 15 minutes, and then we'll move into our break. Hope your conversations were productive. I apologize if you can hear my daughter practicing her voice lessons in our background here. All right, what I'm going to do is call on our facilitators from each of our 4 breakout rooms and ask them to just provide some highlights from the conversation. And as a reminder, the discussion in the breakouts was a little bit different from the discussion in the main room here. The discussion in the breakouts was really focused on, based on what you saw in that initial assessment, what would you like to see be the focus in the next iteration coming later at the end of this year? So I'm going to ask Liz to go first, followed by Mark, and then Suzanne, and then Michael. And what I'm going to ask, as we've done before, is Liz is going to offer some highlights, and then Mark is going to build on that. So he's going to not necessarily repeat what Liz said, but offer any additional feedback that he heard in his room and so on. So let's start with Liz.
Great. So I have just a few comments. Some are about the actual content and a couple about the structure of the report. So number one, I think some outstanding areas that folks identified were that they needed more clarity around how the regional crisis lines are going to work and function with the new configuration of 988, 911. Just better understanding of what that is going to look like and what that's going to mean. Particularly the integration between 911 and 988. There's a lot of questions about that. How is that going to work? Questions about geography and timeliness given the system that's in place and what's going to happen with 988. Another area where people were looking for more information in a next iteration of this document is how are we going to be addressing the needs of communities of color, and what are the issues that communities of color are facing specifically in accessing the crisis system right now. We know that there's a lower volume of communities of color accessing services now because of fear and the inability to get served in the language that you speak and the timeliness of getting an interpreter. A big issue that folks would like to know more about in the next version is the level of commercial plan involvement. It was just seemed a little bit vague, if not misleading, about what commercial plans are doing and what they're paying for. People want to know more about this and what does it mean for the services that are in place right now, and the funding and the lack of communication that is potentially missing to folks who are using commercial insurance about accessing crisis services. Couple comments on the structure of the report. It needed to, hopefully in the next version, we can have our assessment and recommendations broken out a little bit more clearly. And also just how can we make the report more relevant and accessible to people who aren't considered experts? Just being able to communicate about what it means to real people out there. So lots of good comments. I took notes, I'll share. If anybody was in my breakout session, if there's anything you want to pipe up about that I missed, please do that real quick.
Anything from that group to add that Liz missed before we move on? Looks like you did a good summary there, Liz. Thank you. Mark is next, and then Suzanne, you're up after that. Mark.
Sure, thank you. So yes, we had good representation from our breakout on some feedback. So very quickly to dovetail on a few of the things that Liz said, I'll just say them in a slightly different way. But one comment was that for populations that are underserved, we need to ensure that they are going to be served by people like them. So I think that's back to kind of the array of the base of those that are serving and the profile of making sure that all constituents are served in that way. Another comment was about, obviously, the crisis lines have a preeminent role to help avert crises, but there's a whole other kind of type of request that may come in as far as just accessing services and how do I access services if I'm not even in a crisis at the moment. And the comment was that it actually seemed easier years ago to get that information out. So just getting the communication of how to access services, whether you're in a crisis or not in a crisis, kind of resonated. Maybe it could be the 988 lines would be an opportunity to help with that. Kind of common theme across those and other areas was just a focus on training across all the array of service, whether it be the 988 lines, mobile teams, next day appointment personnel that might be assisting in that. So that's back to kind of a provider capacity type of question. And I did remind folks that there is a specific subcommittee outlined in HB 1477 on credentialing and training, and internally, I think what I thought was to focus first on the training aspect before the credentialing aspect, because we need to make sure folks are getting trained as these things ramp up. Another comment, yes, we need to engage more with the commercial plans, learn more about what they're doing and how they can help add to the equation here. And then something else was about interacting with school-based health centers as another means to kind of make connections for youth in crisis. That might be another avenue that we should be exploring, which I know at least some of us had been contemplating. Of all the interviews we were not able to get a chance to do, that was a group that we certainly had in mind as well. So that was a summary from our group.
Thanks, Mark. Anyone from Mark's group want to add anything that might have been missed there? Okay, so Suzanne, and then Michael, you'll wrap it up. Suzanne?
Okay, so there was a little bit of conversation between what we need to be doing over the next year just to be tactically moving forward with a better system. And then what do we really need to be doing versus what goes into an assessment. So let me just, there was 3 things I heard about what we need to do this year. That's not about the assessment, just things to do. And I just want to call those out. Like Liz said, about folks want some clarity around the 988 lines versus the county crisis lines, like to get clear about that, to get clear about a vision so that we all can be rallied around where we're going. And then a third comment about really having strong accountability structures. And I know we're going to actually talk about that, but I just wanted to give a voice that did come up in the group. So the pieces about what could be used to do continuing assessment. More data about the system partners, not just the crisis providers that you think about, the 3-legged stool. We got some of that, but we still need more of that, but we need other data, EDs, law enforcement. We even within the behavioral health system overall, not recognize or not having enough data about detox, how much detox is happening. That's part of the crisis system in reality. And there's not a lot of referrals happening. And so any data that can be pulled together so that you have a clearer vision or understanding about what the system is currently. And we talked too about, do we do that with an assessment, or we need to get clear about the data we need to have? And that's the work we need to do. So we kind of went back and forth a little bit about that. A big conversation about wanting to know a little bit more about the why behind the data that we saw. Why are there so many people going into an involuntary process? Why are those numbers so high compared to mobile responses? Why are there so many, why are police getting involved more often than they need to? It was framed around this year, we need to have a lot of cold, hard truth discussions, and that's how we're going to be able to uncover those truths. We need to, like, why is it there's so many ITAs? Well, we all can probably take a guess at it, but really uncovering that. What about our culture? What about our biases? What about all of that that fosters that? And so some of it, again, it's like, is that the work we do, or is it more of the assessing? It's maybe a little bit of both. And then another comment was to use images more to convey the current status of things. So maybe some more like maps of data, so that people can quickly grasp things. And I think it was either Mark or someone else said, for us to be able to put it in common language as opposed to professionalized. And that would be the last. And if I missed something else of importance, please chime in.
Thank you, Suzanne. That was very thorough. I appreciate it.
It's not just, can I said one tiny thing? It's not just the why, like the cold hard truth of why something is happening, but it's the like, okay, so what are the options on the table to fix it? Like we have to have that conversation this year. And so I think that it's the strategy paired with the analysis.
Uncovering the truth of what's happening and then what we can do to address it.
And when we talk about communities, rural communities, communities of color, etc., we have to remember that youth are also very important, and they have their own culture, their own language, their own style, etc. And yet they are the group that is had the highest increase in suicide and suicidality in the country for the last 2 years.
Can we also be mindful that not all minority communities are communities of color?
That's true too.
Well, can I ask everyone to please, well, hold on. I need folks to use the raise your hand function because I'm having trouble tracking who's speaking. So Representative Orwell.
Thank you. And hearing this conversation, I do not recall, did the report include all the suicide data? Because I think that's important for us to really understand how many lives are being lost.
Amen.
That's a good question. Do any of our report writers have an answer to that? We can come back to that too.
No, it's not in there. No.
Okay, thanks, Mark. Dylan.
Yes, I totally agree about the youth part. I do think I also see some challenges with data collection when it comes to youth. And again, continuing with data disaggregation, of course, is a huge challenge. So there's just like a lot that is, and then to the point around like insurance and commercial insurance, one of the big challenges that I'm facing, and I know this isn't CRIS committee work, but when it comes down to navigating where someone can land after a crisis, or even just be able to connect for services, and so that might be through a grant, which might be based off of certain identities, or it might be based off of a residential or like where you live. And so there are certain areas that have way fewer resources and be able to connect with outpatient mental health services or SUD services. And solving that puzzle after sort of some of the dust has settled after a crisis has always been a challenge.
Thanks, Dylan. All right, I'm going to move on to Michael, and then we'll do a quick wrap up, and Rep. Orwell, I'll ask you to make a couple final remarks before we move into our break. So Michael?
Sure. I'll just lift up some of the points that the group brought up that weren't mentioned already. So several people talked around hoping that the next iteration of the assessment has more information to provide a more comprehensive understanding of the crisis situations happening out there. So like, where are they happening? What is the context? What's driving them? What is working well? What isn't? All the different players that are involved and kind of how they interact with each other, the standards that people are using to assess situations, and like saying different players might be using crisis differently, or the term crisis, and then how we share information effectively and in a manner that protects and honors people's privacy, but allows us to serve them more effectively and avoids re-traumatizing them so that they don't have to tell their stories over and over again. So there was kind of a big, like hoping to have a bigger picture of what's really happening out there, sort of connected to that and kind of tied to some of the data conversations that people have mentioned. They talked about really trying to identify how do we get more data to better understand not just the kind of financial needs to support the kind of system that we're envisioning and designing, but also data to show like who's being served, but who is not being served, right? Where are those gaps in care so that we can then kind of focus on how do we reach those populations. One of the kind of concrete suggestions for the report next time is to include maybe some personal stories throughout to kind of make the report more real for people in the community. So just like people share stories here in these meetings to ground us in this work, maybe do that in the report. Next day appointments was a very specific topic that people thought we needed to work on probably in the next year, and maybe coming up with some best practices or recommendations for how people can get to that point where they can offer next day appointments. And then just kind of overall talk around how do we make not just this report more approachable, but how do we make the system and accessing these services more approachable, even in terms of the language that is used, how we promote the systems so that people know how to get care. And someone mentioned like in certain communities, the term crisis is a big turnoff and they'll deny or they won't identify as being in crisis, right? And so how do we design and talk about the system in a way that will really ensure accessibility? So I think that's probably the highlights.
Thank you, Michael. I appreciate it. Anything from Michael's group to add to what he shared? Okay, Representative Orwell, I was reflecting on a comment that came out of Suzanne's group, and actually I heard from a couple others, and the conversation we were having in the main room here, which is about having a clear vision for where we're going. So would you mind just sharing some brief words about hearing that feedback and what the plan is, and then I'll let everybody go off on break.
Yeah, no, thank you. And I just thought the conversations I heard were just very thoughtful, and that we're really opening up and talking about the parts of our system that are really failing people. And I think that's so important. And it's not enough to say what's broken. I think it's having that discussion of how we fix it, which I think is the vision. And so I really appreciated hearing both. And a common theme for me was our current system is harming people. And how do we create a system that does not, right? That really provides that assistance and is approachable and safe. And so, again, I just appreciate everyone identifying really what's broken and really where we're headed together. Thank you.
Thanks, Representative Orwell. And I just wanted to add to that based on the feedback that was received about having a clear vision, we are convening an ad hoc committee to work on that vision and advise the steering committee. So the conversation we were having in the main room while the CRIS committee members were in breakouts was what kinds of ideas do you have for what you'd like to see in that vision? So we had some great discussion. We're running short of time, so I can't debrief too much with you about it, but I will make sure that you get notes on it in the meeting summary so you can hear all about it. Everyone, we're running a little behind, but we still owe you a break, and I definitely want to give everyone a chance to stretch your legs. So let's reconvene here at 5. Let's reconvene here at, I have 5:08 right now, so let's reconvene here at 5:20. Sorry, that's wrong. That's too much break. Let's reconvene here at 5:18 with cameras on, and we'll move into our next breakout. See you at 5:18. Thanks, everyone. Okay, welcome back, folks. While we're waiting for folks to come back on camera, I also wanted to acknowledge, I know a number of you are very involved in the legislative session. So we do have some of our legislative members who are in committee meetings and other legislative activities today, which is why they're not here. And I know a few of you are also testifying and have other responsibilities with respect to session. So I want to acknowledge that, appreciate your time here today, and also acknowledge that that you may have to step out here or there. Kathy, I see your hand up. It looks like you have a question.
I just wanted to ask something. Is everybody aware of the fact that every region has a family youth systems partnership roundtable? There are local ones that are smaller, like there's one specifically for King County. It also acts as a regional one. There's one in Pierce. They're all over. I helped start them. It was under a lawsuit settlement for a young person against the Department of Behavioral Health and Recovery. And that's how they came to be. And I spent 4 years in 10 counties of the state, helping get local BISPERTs, they call them BISPERTs, off the ground. And it seems like that would be a great place for us to be getting some youth voice and some family voice into this process. I mean, I'm reading about triaging, and I'm reading about, we talked about the qualifications for someone. And I wanted to say, I really liked what the one lady said about, bachelor's level clinicians have a different skill set. I think peers do, and I think there's different kinds of peers as well. And I think the youth peers are the ones that we don't quite see, but their expertise with other teens or young adults is something we can't afford to not look at.
Thanks so much for raising that, Kathy. And yes, I did hear from a couple of you in your discussions that bringing youth voice to this table is really going to be important in that next iteration. So thank you for raising that suggestion. I appreciate it. Welcome back, everyone. We are going to be moving into our second group of breakout discussions. This one focused on taking what we learned from this initial assessment and forming a subcommittee work plan moving forward. So hopefully you had a chance to review the draft work plan that Nicola sent out to you last week to prepare for today's meeting. I'm going to ask Amber leaders to take a few moments to set the context for our next breakout discussion, and then I'll give you instructions before you move into your rooms. Amber?
Thanks, Jamie. Like Jamie said, this is really kind of a high-level work plan. It puts together and articulates our overall objectives for the work ahead, and is really designed to be kind of the overarching look at all the work that's going to go forward, particularly through the committee and the subcommittees. It's organized around 5 primary objectives, each one which is framed around our core crisis system services and infrastructure areas. Like Jamie said, there were some materials on this, and you'll get a chance to talk about these in more detail on what they cover. But the 5 main areas are around the call centers themselves, the mobile crisis response teams, crisis stabilization, pre and post crisis care, so immediately upstream and downstream from crisis events, and the general crisis system infrastructure and oversight. And so we're really looking for the group today to kind of chime in on whether or not the objectives that we have outlined in the work plan are the right objectives. Do we get them right? Do we have the right ones there? And what are the issues or key objectives that might be missing in the work plan that we have ahead? And just a reminder to folks, I think we've talked about this a few times in these meetings, that the work plan is not just a reflection of the work in the subcommittees, but DOH and HCA are doing a lot of work around implementation. They have entire staffs of agency people who are working on the work around 988 on a daily basis. And so just keep in mind, this is intended to be really high level, the main sort of core objectives, and doesn't necessarily cover all the intricate details that go along with all the work that is happening. And that, the charge of CRIS and the subcommittee is to help inform that implementation with recommendations and advice. And so this is really an opportunity for you all to look at have we hit the right mark on the core objectives? And are we assigning out the right tasks that are going to go out to our subcommittees in terms of the categories and areas of work that we're gonna be doing. So I think with that, I'll hand it back to Jamie for some additional instructions.
Thanks, Amber. I appreciate it. All right, so you're actually going to be going back to the same breakout discussion groups, the same composition as your previous one. I make your breakout groups for every CRIS committee meeting, and I'm going to make a real effort and have been to make sure I mix you up and give you an opportunity to engage with all of your colleagues. So even though you're going to be seeing the same people in your breakout room today that you've worked with already today, next time we get together, you'll be mixing up with a different group. You'll also have your same facilitator. So hopefully you'll have some rhythm already. You're going to go into your breakout rooms for about 25 minutes, and then we're going to reconvene here for 20 minutes of larger group discussion. Members of the community, you're going to stay here with me, and we're going to have a similar discussion. I'm asking you the same questions and get your feedback on the subcommittee work plan. So with that, Brittany, if we're ready to go, you can send folks to their breakout rooms. All right, community members, feel free to turn your cameras on if you want to participate in this conversation. So what I wanted to do was reflect on the draft work plan that was posted in the meeting materials and get your feedback on the objectives that we've centered the work plan around. So as a reminder of what Amber said, we based those objectives on the outcomes of the initial assessment and the feedback that we received from all of you and also our CRIS committee members. First, I want to ask, did everyone get a chance to look at those materials? Because if not, I'm happy to, okay, you know what I'm going to do is I'm going to post the link to the HCA website in the chat. And if you'd like, you can go there. If you scroll down to the agenda, it's not the correct link. Let me try that again. If you scroll down, you'll find a link to the CRIS high-level work plan. If you go to the 2022, there we go. Laura, I figured out, it finally worked. I was able to get a hyperlink in there. I'm not sure what I did miraculously. Laura and I were chatting about trying to make these a hyperlink so that you could actually use them. So if you click on that and you scroll down to the meeting schedule materials section, if you click on 2022 CRIS committee, you'll see next to Tuesday, February 1st, there is a document, a CRIS high-level work plan. And you can click there and take a few minutes to look at that. In the meantime, for those of you who have had a chance to look at it, I will start talking with you about it. We'll have some of the same conversation that our CRIS committee members are having in the breakout rooms. So as Amber mentioned, we centered this around 5 key objectives. And the first is that subcommittee members need to work out that place to call, place to contact, specifically the National Suicide Prevention call centers. And there's a number of objectives in here sub-objectives that we are hoping subcommittees would tackle this year. And they include things like making sure appropriate technology is in place, and that there's a standardized process flowing between the 988 National Suicide Prevention Lifeline Crisis Centers, crisis services, and 911. So what I'd like to do is, if you have a chance to look at those, let me know if you think these are the right objectives and what you think might be missing. And I'm going to start with Laura.
I have my hand up.
Yeah.
So should I jump in?
Yes, please.
Okay, great. Well, we have limited time. So I just want to go to 3A and not have a debate on this, but just feedback from each of us. And that is that I'm a little surprised that there be a place to go that is crisis stabilization. services, which would probably be a crisis stabilization unit of some kind. And I realized that one has been opened up, brand new, and I'm forgetting where it is, but attached to a hospital, if I'm not mistaken, and very impressive. And I know Representative Orwell was there to do like ribbon cutting. So here I am going, you know what? Can we have alternatives besides mental health units? So I really, just want to put that out there. There may be communities that that's all they have as a crisis stabilization unit, but I know there'll be other communities with more population where we really need to look at, again, I don't know, this kind of hits up against the point I made earlier in terms of where are we inviting people to go post-crisis or even during crisis.
So Laura, if I'm understanding your concern correctly, it sounds like your concern is the way this particular objective is framed is very limiting. It seems very focused on these crisis, the crisis
stabilization,
and you'd like to see them broaden their thinking about the.
Thank you. Okay, that's great. Thank you.
Okay.
We can move on now.
Okay, so I heard you correctly then. Okay, good. I just wanted to make sure I was capturing your point. Thank you for that. Sarah.
Yeah, I'd really like to just elaborate a little bit on Laura's comment, because coming from, I'm not here just as a personal advocate for stuff like this, but I also work in this field professionally. And I've worked in crisis stabilization units, and the way that this is worded to me almost sounds like, walk-in services. And a lot of these places require referrals. I can't tell you how many times somebody actively in crisis has shown up at the doors of my facility and is like, I need help, I don't know where to go, things like that. And we literally have to call the crisis line for them, take them to the hospital, something like that, because they can't access services at our facility without a referral, which is a very, very long process. And to send them to the emergency room, or to send them to call the designated crisis responder or something like that out, is really traumatizing for them, because they already are not really knowing what's going on. So I think that the way that it's worded almost sounds like, are we going to try to open up facilities where it's almost like, okay, yes, you can come in no matter what the circumstances are, and maybe find a more appropriate placement for you after that, kind of like not shutting the door on them, like you can't come here, you don't have a referral type situation?
So Sarah, it sounds like you're echoing what Laura's concern was, that because of some of the limitations that you've observed, for example, the very long and onerous referral process for someone in crisis, that we need to broaden our thinking and maybe address some of those barriers that you're highlighting to even being able to get into these facilities.
No, but the reality is, and I'll be fast here, the reality is that there are big developers that are developing these units. And so it's not only that, but it's sort of the commercialization of illness. And I realize that some of that's needed, oh my God, I go to Kaiser, of course, there's a foundation, there are lobbyists, there are people that make sure the building is up to code, but it's a whole new line of work. And I'm just a little bit concerned that we not fall into kind of a medical model. Maybe that was really my overarching point.
That's
perhaps what Sarah was saying as well. I agree, there can be a whole lot of confusion.
Thank you for that clarification.
And so forth.
That's really helpful. Thank you for that clarification. I see Jim Bloss's hand up, and then I have some comments in the chat that I'll share with you. Jim? Jim,
right.
Right.
You've got me blocked video, but that's okay. Nobody wants to look at me anyway.
I'm so sorry. Let me see if I can get you video. There we go.
Let's see. Oh yeah.
There we go. Hi, Jim.
How you doing? How you doing? Nice to see you all.
Nice to see you.
I was just about to type in in the objective 2. To me, the mobile crisis teams are likely the key. Perhaps I've read material from decades ago that outlined that mobile crisis teams are probably where it's at, particularly having somebody on the team who is a peer, certainly, but best even a peer, a diverse peer. Would that be the the proper term to use? Somebody who actually could converse with the person who is in need, who is in crisis at that particular point, in a way that would really settle them down. And I really go back to the CAHOOTS model in Oregon. I mean, I haven't been able to take the time to compare the details of how the CAHOOTS model is put together and our objective two. The second objective, I mean, mobile crisis teams, but whatever can be stolen from the CAHOOTS model to beef up and make that mobile crisis team objective be almost a central focal, the first thing to really get funded and money, and about one for every jurisdiction. There are 39 jurisdictions. I mean, the state's divided in all sorts of different ways by managed care organizations and interest groups and so on and so forth. But for every county, every one of the 39 legislative districts to have a CAHOOTS oriented mobile crisis response team 24/7 it'd change the whole face of the way we do behavioral healthcare business, I really believe.
So Jim, for those of us who, and forgive me, I might be the only one on the screen who's not familiar with the CAHOOTS model, but
it looks a lot like what you have in objective two.
Okay, got it.
But I don't know what's missing.
So it sounds like I'm hearing, let's not reinvent. Let's build on best practices.
It's evidence based. They've been operating for a while and they work.
Oh, thank you. Okay, so I'm going to pause for a moment. I've got a couple of comments in here from folks that I want to
thank you for
offer up.
My time.
Thank you. Let's see. There was a comment when we were talking earlier about the mobile crisis response unit that Laura reflected on. Melanie shared with me that it's in Everett, Providence Hospital in Everett, where it's open. It is fantastic. And then Dawn had a question. I think this might have been first from Sarah's point, which is wondering about that referral process. Is that a facility policy or a lack of beds and space? So Sarah, I don't know if you have an answer for that, but that's a question that came up. I heard from Joe Rozak a concern. Our current behavioral health system in Washington state is near crisis status itself. Over 50% of the community behavioral health centers have closed the front door to new admissions. Workforce shortages and decades of low Medicaid rates have severely hurt many service providers. We need to take this into consideration as we amp up a new crisis referral system. So Joe, I'm curious if you think, how you think that might be reflected in the objectives in the work plan. You're raising some concerns that I've heard over and over again regarding workforce and low reimbursement rates. So thanks for bringing that up. I heard from another Jamie that I would like to hear from someone that has been visited by a mobile crisis unit and how that benefited them or not. So if anyone here today is willing to share their experience having been visited by one, if you could raise your hand. Okay. Oh, great, Laura. Okay, I'm going to call on you in just a second. Let me just get through these chats and then I will call on you. Laura had a comment, objective 4, bright blue text, person-driven services unless requested that others participate, basically flip the language, and asked what's the role of psychiatric advanced directives. Let's see, I've got a link out CAHOOTS model. All right, I'm going to pause there. Laura, why don't you, if you don't mind sharing.
I didn't know that my chat was going to be read out to everyone, so I'm writing in shorthand.
Oh, I'm sorry.
May not understand. But someone can call and ask me. Yeah, I actually was attending well, CAHOOTS was a major theme of this 2-day conference. I left early to come to this meeting, and it finishes tomorrow midday or so. But it's actually a law and police conference, very interesting. They brought in a lot of other models around the country, Minnesota, several other that I can share another time, but I actually was a recipient of CAHOOTS services, and a couple of weeks ago with other people who also received their services, did training for their staff, and about 25, 30 staff. And it was remarkable that we could come back from our own experiences and help do training. My experience was in 2014 and 13, 2014 and 13, and I was homeless in Eugene, and both instances, I can just tell you, they really left a mark on me because of how they were as people. Number one, they all dressed in black. Number two, there was something hip about them. They had tattoos, they had earrings, they looked like, modern people, but young people, and and they had the equipment on that they needed, but there was just something about who they were and how they spoke and how they interacted with me and how I watched them interact with actually other women at a women's shelter that I was a resident of. So I received services at a shelter, suffering from, I call it behavioral health symptoms. And it was somewhat urgent that the shelter called them, and then they came in their van, and it was an issue of whether or not I needed to go to the hospital, not just for psychiatric reasons, but physical reasons. So they were able to actually triage a situation and help me relax, and then they went on about their way. The second time was when I tried to leave the shelter in the middle of the night. I guess you'd call it sort of against kind of quote medical advice. And they were called, and they came in the middle of the night, and they heard my story as to why I wanted to leave. And it was like 2 or 3 in the morning. And I had my bag with me, and I was like ready to walk, but the shelter wouldn't let me out. And so the cahoots came and kind of did a negotiated conversation, and I was able to leave. Turns out it was not a good idea to leave, but that's what for me, it was not a good idea later, hindsight. But they were there to kind of represent my wishes, not knowing that what happened after that was sort of not even in their purview. So I just want to say, that it was really how they spoke to me, how they position their bodies in terms of like crouching instead of towering over you. They were extraordinarily adept at listening and letting a person speak their piece. So I just want to say that they've been in existence for 30 years. They were started in a way by, in a healthcare clinic called Whitebird. So Whitebird Clinic is how you can find them today. Cahoots is still there. And they've really gone national. So their top staff were training today, just excellent people. And I hope that that we can take a page from their book and and see what we can do in Washington. They've actually come and spoken to a planning group that Representative Orwell had. I forgot the name of the committee, but they did participate, and they've done a couple of things in Washington state already, but obviously nothing yet, widespread because they're not here yet. So, and I'll never forget that I actually laughed when I saw their van driving through Eugene. I saw them before I ever needed them. And the van says Cahoots, in big print. And I never thought that they'd be called, but I thought it was the funniest name in the world, considering what, what happens in the mental health system. So
I would love to know what they came up with.
I should say sometimes, but I would, I tip my hat to them, and I think that they are fabulous. There are cities now, Denver, other cities that have replicated parts of their model. So their model is not like McDonald's, there are bits and pieces that can be replicated. and those left by the wayside. So, you know, that's that. So I hope that answered anybody's question.
I so appreciate you sharing that, Laura. That was very, particularly the detail in how you described the way they interacted and showed up for you. That was really, that was really helpful. I got a question here from Jim Bloss asking if the CAHOOTS folks approach seemed akin to the peer respite approach to behavioral healthcare. Do you know the answer to that? Oh, I think you're on mute again.
What's the question?
The question is from Jim Bloss. He asks if the CAHOOTS approach seemed akin to the peer, capital PEER, respite approach to behavioral healthcare.
I think to some degree, except it's not housing, and there aren't, you know, extreme limitations on residential there. But Oregon, by the way, which is where CAHOOTS is located, has a big bill about peer respite now being bantied about in their legislature, not yet funded, but they hope to fund 4 of them at least. And I think it would be a great partnership. I say it's more of an alignment with the respite model.
I just got an answer to my question. CAHOOTS is crisis assistance helping out on the streets. CAHOOTS. Love that. Melanie, thanks for your patience.
I don't know if Sarah was able to speak. Looks like they had their hand up before me.
Oh, I'm so sorry. I missed that. Thank you, Melanie. Sarah, and then Melanie. Sarah?
Well, thank you, Melanie. I was just trying to answer the question about whether it was a policy or lack of available beds. You know, honestly, it's policy, and it's not just that company. It's not just my company. It's companies all over. You know, down here in Clark County, we have Columbia River Mental Health. We have Lifeline Connections. We have Rainier Springs, and all of them require either an extremely long wait and process where you might not even get in, or they require a referral. So, I mean, I think that there's just a lot of red tape, and people in crisis don't care about red tape. And, you know, and honestly, they're right. They shouldn't, you know, and we shouldn't care about it as much as we do. So I think that, you know, the ability to be able to open these quote unquote walk-in crisis stabilization services, or even provide a safe place for them to go while this, you know, red tape is being figured out, would be huge. I really think that that's something that's absolutely needed.
It sounds like it's a systems issue too, not just an individual.
Yeah, it's not just individual companies, it's systems everywhere. I mean, referrals are referrals. You need a referral to go to the optometrist from your PCP, you know, same situation. So
okay, thank you. Appreciate you sharing that answer, Sarah. Melanie.
Yeah, I see we have 5 minutes left, and I know I've already spoken, so I'll keep it quick. I just wanted to comment how surprised I was, again, that workforce was not mentioned at all in this document that you were sharing. I've also worked in the mental health care field, and the biggest thing I was always told by my clients was, hey, you're case manager number 64 for me. How long are you going to last around? 5 months? Why would I tell my story to you? You're going to leave. And like oftentimes those direct service positions are sort of like boot camp for getting into a master's program. And, you know, we can make this system as robust as we want, but if we don't have anyone that's really skilled in it, it's not going to be successful. And so I'm surprised we're not thinking about, especially given the great resignation right now, how can we make these positions attractive to people? How can we make this a system people want to work in and know that it's a sustainable career? Because I don't know about you all, but I wouldn't want to be a nurse right now. I wouldn't, if I was, you know, entering college, I wouldn't want to be entering this field. So how do we make it attractive is something I think needs to be part of the conversation right now.
So it sounds like workforce and an objective around that and some sub-objectives would be something you'd really like to see the subcommittees tackle in 2022 and advise the CRIS committee on. Okay, great. Okay, I've got a few more comments in here. So Laura asked, and Laura, I would love if you wouldn't just mind briefly elaborating, because you had a concern about these being called high-level objectives. Maybe it sounds like you feel like that's overused, that term, based on what you've written here. Why not themes or overarching? Did I have that right?
Yes.
Okay.
Gets on my nerves.
Fair enough. I understand. Some things were just overused. And then you suggested separating person-centered from objective 5 and give it its own objective. Great suggestion. Sylvia offered for objective 2, we need to change the wax as to who can respond to a crisis. A peer is not allowed to do a risk assessment, but can certainly do a lot of good. A lot of the bills passed by legislators in recent years require DCRs to be involved in crisis. Joel's Law, Ricky's Law, Shenna's Law. Community and hospitals have defaulted to ask for DCRs versus being open to other responders. Workforce issues and retention of staff that are willing to do this work, graveyard, weekends, holidays, and respond to very unsafe situations is a problem. Our team also still uses personal vehicles to respond, unlike other first responders, something to consider when it comes to funding. So Melanie, I think that actually might have even come in while you were talking. So there's clearly some common thinking in our group here. Okay, we got our 1 minute warning, a couple more. Laura offered objective 5.7, remove minimum from the statement. I'm just going to read that to everyone so they can follow what we're talking about. Statewide minimum standards of operational and clinical practices are developed that foster use of best and promising practices, while also allowing for tailored implementation at the lower level. I hear Laura saying, drop the minimum, let's just have the standards, right? And then Sarah, attractiveness for the positions will also play a role when talking about all the needed peer positions that we were talking about before the breakout. Peers are so underpaid. And then I see DCRs have too much power. Oh, I see a lot of snaps there. Okay. One of the things I really appreciate about this community is it sounds like you all have both great new contributions and a lot of support for each other's ideas. So that really helps us actually, I think, come up with a system that works. All right. Well, while we're waiting for, yes, Laura, saying minimum gives permission to go low, and you would like to see a higher standard here. While we're waiting for our CRIS committee members to return, I just want to thank all of you for engaging with me today on this. You gave us a lot of good information and ideas to think about, both in terms of the next iteration of the assessment and the work plan. So thank you so much for your time. Welcome back, CRIS committee members. I hope you had some good discussion. We'll go back to, if you are on the CRIS committee, please leave your cameras on. And if you are off, if you're a community member, if you wouldn't mind turning your camera off now, that will help me facilitate. Oh, we got a question from the chat. So I'm going to just asking for some clarity on some of the conversations we were having in the main room. So I will address that separately. Right now, I would like to hear a debrief from our CRIS committee members about the conversations you were having in your breakout rooms. So we're going to do the same routine. I'm going to start with Liz, followed by Mark, then Suzanne, and Michael's going to wrap it up. And I'm going to ask each facilitator to share highlights from your room. If you could keep it to about 2 to 3 minutes, because I'd like to leave time for all of us to have a discussion and really process what we heard. So let's start with Liz.
Can we have someone else go first, just because I have someone that's chatting to me, it's something that they were trying to finish up saying?
Oh, absolutely.
Sorry about that.
Yeah, I can go.
Mark, you'll go for it. Thank you for volunteering. Mark.
Sure, that's fine. Amongst the comments, I think there was general consensus that the overall objectives, in the document, those in like the dark blue, were fine. And they covered the bases, if you will. On the particulars, there was a request to make sure that workforce development is specifically articulated somewhere in an objective and it has a home somewhere that somebody's going to be addressing. Another one was that under objective 2 is that before we get much further talking about mobile crisis response, like what is that? Who does it? What does it encompass? Who might employ these folks? Like, just better define that as a function. But was something else that was brought up. I think we didn't articulate this at the very beginning because we didn't want to presume there were not going to be other objectives, but the thought was, and luckily the CRIS committee members already brought it up as well, is that each subcommittee needs to have a charge or a charter, whatever we want to call it, so that as they embark on their work, they know what their charge is, clear expectations and timeframes for them to deliver what they're being asked to deliver. There was a request for a little more clarity about what the columns were about the dates, the July 22, Jan 23, and July 23. And so I described it as kind of, not that everything doesn't need to be done, it isn't all important. There are some things that are very high priority, like standing up the 988 line. So that's why some things are in some columns versus others, but there could be a cadence that crosses a longer period. I think those were the main items from our group.
Thank you, Mark. And just a note, I heard from Jen that the term mobile crisis isn't used in our state. The term is co-response teams. That's a fact I did not know. Thank you, Jen. Liz, are you ready now, or do you still need a little more time?
I think I can be ready. I'm going to just ask Claudia to pipe up if I don't mention what she said.
Okay.
Lots of echoing what Mark said about workforce. That was a big issue. Folks felt like we jumped from kind of creating the system and getting people connected, and then all of a sudden we have an equitable system that's serving folks, and that we've got to be starting on addressing workforce like yesterday in order to be able to ensure that equitable access. And when we talk about workforce issues, we need to be talking about not just making sure folks are paid enough, but we have enough people so that we're not burning out the people that we do have. The other comments that we heard, I thought really important one that was brought up was that the issue of a culturally responsive system, it needs to be weaved throughout. It's only called out once. And so all of these objectives need to be including issues around design and serving communities, different communities. So I thought that was really a lot of energy around that in our group. There were some specifics around some objectives around making sure that for interoperability between the regional call centers and 988, that the standards for text and web-based services address issues of data sharing and security, and that we have a disaster and preparedness plan if systems fail to make sure that these services are able to still operate and serve folks. Just going down my list here. We need to have more clarity around what crisis stabilization means. So for objective 3, we say a place to go. It can mean a lot. And so we need to clarify what it means and what it includes, and then have a list available that is regularly updated about what we designate those services to be. And for objective 2.2, more clarification around the involuntary versus voluntary process. If we don't do that early on in our design, we're gonna hinder our existing first responders and providers from being able to respond effectively. So we need to do more around for objective 2.2. So those are the high level comments. There were a lot more details on specific objectives, but I think if that captured it, Claudia, I don't know if you wanted to say anything else.
Yeah, just maybe adding a comment regarding to the workforce that we talk about, the issues that we have with workforce, and when we look at the goals, we have to keep in mind that is a clear issues with workforce. One of the bills that are in process right now is also to identify a behavioral health provider who will be billable under our system. And I think that will really help us to kind of address some of these issues, because some of those the new behavioral health provider is also part of communities of color, where they don't have, some of them don't have a master's degree, but there's still a very key bridge between the crisis system and the community. So I think these goals are tied up with the other bills. They are in place, right? Or they're even in the process right now.
Thanks, Claudia. And I'll just add, I don't want to sidetrack us from our discussion here, but I will add that workforce came up pretty heavily in our discussion in the main room too with community members. So this is clearly an important theme on folks' minds. Before I move on to Suzanne, anyone in Mark or Liz's room who wants to add anything else that we missed there? I do have a couple of chats. Let me just offer up those. I heard something from Michael. We need to be careful as we move closer to addressing crisis identification. Aesthetically, we cause damage if we show up as unwitting agents representing trauma in the wrong spaces, even in goodwill and even thoroughly trained. Culturally, we can be in opposition intrinsically and transmit damage instead of offering healing. I think this is building on our culturally attuned. I heard someone say culturally humble care. I think that was Dylan, and I really appreciated that phrase earlier today. And then let's see. All right, let's move on to Suzanne. Suzanne, what does your group have to add to the?
Okay, first, I just am so impressed with the wisdom and collectiveness that so many people bring to the table. So thank you. I will try to go, there was so many important things and I'll try to go through this real quick, but just the whole concept of like, we're talking about objectives and we still haven't collectively come to agreement on a vision, and just the challenge that brings to opining on thoughts about the objectives. And certainly that once that's decided on, probably relooking at objectives, do they align with what we're attempting to do? Also, not only have a vision and goal, but we need to do some more definitions to have a shared, like, what is crisis? Are we all, when we're using those words, we're not all maybe meaning the same thing, and certainly rethink the timeline and what do the X's mean, and thinking about sequencing. This was similar thing that we had earlier. Language needs to be a little bit easier, to have more plain language, to have more people understand. And so maybe getting some feedback on when something's written there, is there another way to write that? A comment about, first off, we don't have the vision, but we do have some prescribed subcommittees, and maybe once we land on these objectives, that might change what subcommittees you really need to have, or maybe they need to just get rethought to think about that. Then there was some specifics. One I just want to call out, but there are lots of examples like this. Like in objective 3, we need to call out things like about the EDs. So objective 3 is about the place to go, and how does that all work with the EDs, and to call things out more. And the last thing I want to draw to attention is in objective 5, we talk about having braided funding, but we need to call it out more specifically about what commercial, Medicare, what are we going to do to get feds to really be thinking about Medicare's responsibility and payment for all of this? And so really detailing out more of what that means, braided. Like there's an example, braided funding. Well, what does that mean, to get clearer about that? And if so, if there's anything else that I didn't share from our group, that's when you want to bring to our attention, please chime in.
Too many feedback from Suzanne's group. Anything we missed here? Jen.
Oh, I think I just want to add that I was really struggling with, I think our group was really struggling with kind of the timelines. And I realize some of it is, I think we just need to kind of come to this reality that, you know, we need our kind of proposal for the legislature for next session, for the next biennium. And obviously, and that means if we don't have that, like we're going to kind of continue to do this piecemeal thing. But, you know, reality is we're going to be waiting like 3 years if we don't kind of come up with something, you know, in the next 9 months. So like in some ways I felt like, you know, there are some like very high priority issues that need to be dealt with, like including the questions around just in the short term, what are we doing with this platform? Not even the long term, because I recognize we can't do that, but what are we doing with the short term and with the platform geolocation? How are we addressing that? Like stuff is serious that's bubbling up right now, but then we also really do need to kind of think about that, the comprehensive plan, like with really a due date, I think that like precedes the next ledge session.
And Jen, you're articulating something that a few of us were talking about earlier, actually, that constant tension, that balance between meeting the urgency of the moment and then feeling like we're doing it justice. So Betsy, do you have any, you had some good words when we were talking about this earlier. Do you have anything you want to jump in here before we move on to Michael's group?
No, not really, Jamie. I'm hearing, as I've gone across the breakout groups, I'm thinking about these things and how we balance that tension and how we prioritize. And, I've been thinking today about one giant process map and how we understand, scopes and roles and responsibilities and technology and policies and procedures and protocols. And, it's a really daunting task, but thinking strategically as we approach next ledge session is kind of what's top of mind for me. So, it is that balance between, the sense of urgency we have and getting it right. And so I guess I just said more than I was intending to say, but I appreciate people's acknowledgement of the same thing as we kind of grapple with these questions.
Thanks, Betsy. Let's move on to Michael's group to wrap it up.
Sure. So a few things that I think my group would probably want me to reinforce that came up in others is definitely the workforce issue. Disaster planning was another one. And then the culturally responsive, culturally humble care, and kind of along with that, aligning and respecting tribal sovereignty, and how does that, the tribal work showing up here. Some new things that came up that weren't mentioned. One is communication plan. There's really this need for a strong communication plan in all of these objectives, probably for like the broader community, but also for providers who are doing these services to know about everything that's going on. Kind of tied to that is a better understanding of the kind of how this is all going to work, the coordination, how calls are going to be routed, what they're going to be based on, so that people know when they're getting calls, where they're coming from, what region they're serving, and how to access the services to make sure that people get what they need. Telehealth came up as well, especially for some of our more sparsely populated areas. And so should there be something specifically about telehealth? There was some conversation around this idea of not just mobile crisis teams, but integrated mobile crisis teams. So what is the composition of those, and can they pivot and respond to the variety of needs? Crisis, someone said crisis doesn't always happen in a linear fashion. And so teams need to be able to respond quickly. Also paired with that was this idea of rapid response crisis teams. And so like for a subset of calls, they might need even more rapid response. Are we talking about that? And then also this idea of, how and where are we tackling or talking about police encounters that really should be crisis team encounters, right? And does that fit here, or where does that fit in this? So I think that was kind of the new additions I would add from our group, and welcome anyone else to chime in if I missed anything.
I got a thumbs up from some people on your team, so it sounds like you did a good summary there. I just want to share a few highlights from our conversation in the main room here too. As I mentioned, workforce came up as a really important objective for our community members who were talking with me. There was also some sensitivity around some of the language regarding crisis response units or co-response teams. To use the corrected language. There was some sensitivity around crisis response units. Sorry, I think I'm getting the two terms mixed up. I don't mean mobile response units, but crisis response units, and that it might be a little bit limiting. And what we're looking for is language that allows for a lot of different ways to respond to people where they need it in the way they need it. That was a theme that came out of our conversation here. A lot of other good feedback in the main room. Thank you, Laura. It's crisis stabilization units. Thank you, Laura. I have to work on my terms. I think I need to put together a little cheat sheet for myself for these meetings. So a lot of good feedback in the main room that we'll compile and share with you also, because our community members really contributed a lot today, including some personal stories about their own experiences that were really powerful. I also heard a lot about the CAHOOTS model in Oregon and a lot of enthusiasm for how well that works. I see some nodding heads on the screen, so it sounds like that's familiar to all of you. Before we move on to action items and next steps, any final thoughts from our committee members? Any other ideas that came up for you? Puck.
Another thing from, I think, Michael's group is that often people might receive different care based on their insurance status, et cetera, and based on whether they have a provider or not. And I think something about, there was that cross weaving thing, but like highlighting more of ways to respond relevant to people's insurance / provider status, but also not limiting that for how responses are.
Thanks, Puck. I saw a question about circling back to some questions that were raised by Kimberly Hendrickson regarding implementation of the 988 line. I think Michelle covered a bit of it or a lot of it in her update answering the questions, but maybe I can just circle back to Michelle briefly to make sure that that Kimberly and others who were raising those questions feel like they know what's happening next with them. So Michelle, do you remember, is Michelle still with us? Maybe Michelle to jump off. Oh, there you are. Sorry about that, Michelle. I had to scroll through a couple screens to find you. Sorry about that.
Yeah, no, and I don't, yeah, I did touch on some of these, but I want to make sure, I don't think the whole CRIS knows what the questions were. So do you just want me to go through them? I think that only came to some of us, Jamie. Okay.
Yeah, if you don't mind, Michelle, just reading them quickly, and then I think you covered some of the answers, but if we can just clarify what's happening next with those questions, that would be great.
So one question that came in was whether or not Vibrant, who's kind of the national administrator of the National Suicide Prevention Lifeline, so the 988 call centers, asking if they have shared details on the IT technology platform that they are putting in place. And we do not have those technology specifications yet. They're just have selected a vendor for design and development of a unified platform, which call centers would use. And we're connected to that work and anxiously awaiting for more information. And Levi, who was on from Volunteers of America, is part of the implementation committee. So another door in there. So more to come on that one. Then there was a question, and Jen Stuber mentioned this a few minutes ago, geo-tracking of 988 calls. And is it a requirement of the new platform? So at the national level, call routing for 988 call centers is managed by Vibrant, again, this national administrator. We need a lot more information from them about how they're going to use geolocation in that. But we don't have any more details about timeline and any specific new directions. At the state level, we know that providing services that are geographically relevant is really incredibly critical, which I think is probably behind this question, as well as needing interoperability to occur with 911 and other crisis services. And also we were talking about just the, the need for information and resources available in different communities across the state. So key elements to the work together. So continuing, there's work to do to sync information about how that fits with what's going to be happening at the national level, and then what needs to happen for the state's technology plan. And last question is if the current 911 platform has been explored as an alternative or add-on to the Vibrant system as an interim measure. So it's a requirement in 1477, is I think most of us are tracking that the 911 system is interoperable with our final 988 solution. The project team has explored utilizing the 911 existing SAT system and have determined that the system may be feasible, but however, information regarding the functionality of the Vibrant platform is still needed to see how are we going to get there with interoperability with 911. So most of the answers, they're great questions, and most of them they're still to come.
Thank you, Michelle. I see a couple of hands. I also want to acknowledge that we are running into the time where I need to move to our public comment. That said, I just checked and I don't see anyone who signed up for public comment today actually still on the meeting. So I'm going to buy us a little more time, but I don't have time to take a lot of questions. So I apologize. If there are follow-up ones, Again, please send them to us via email and we will work on getting the responses. Adam, Kim, Jen, we do have time to take a couple of your questions, so don't feel like you have to hesitate here. I saw you put hands up and down. Kim?
I'll just jump in very quickly, and thanks, Michelle, for answering those questions and sharing them with the group. A lot of these questions came out of a very useful conversation that a small group of us had with Adam, with VOA. I just would like to say that as a CRIS member, I'd be really interested in exploring from the 911 perspective, what options might be available and at what price on the off chance that a launch on the Vibrant platform isn't possible on the date that we're looking for. So I understand that Vibrant's coming. Vibrant has a vendor that is our future in Washington State, but as just an interim measure or something to think about as an alternative if the launch isn't as quick and as seamless as we hope, just would like to express my interest as a CRIS member to learn more from 911 about what they're capable of doing, how quickly, and what the cost might be. Thank you.
Thanks, Kimberly. Adam or Jen, did you have anything to add there? It looks like we do have a few more minutes. Adam?
Yeah, I won't go into too much detail with the 911. That's on my, I can answer, but that's probably in a different area. One of my concerns is, you know, we have a 911 system taking over 5 million calls a year. And I hear a lot of talk of there's going to be interoperability, but, you know, I'm not hearing anything from Vibrant of what they're expecting to interoperate with us. And I hope they don't expect we're going to change our system to interop with a Vibrant system that doesn't exist, or I have no idea. So those are just some of the concerns that I have, is that they're going to expect us to change our system to meet their system when, yeah. So the more information we can get, and I know, Michelle, thank you very much. I know you're trying to get that information out of them. Anything we can do to help pry that loose from them so we can get started on it, we'll do. Thanks.
Thanks, Adam. Jen?
I guess I would just say that I think I was hoping that we would have kind of more movement more quickly on the Vibrant platform. And of course, that's not the case. So how do we make the best of kind of a challenging situation? And I do think that kind of understand, and actually in some of the Vibrant documentation that I was looking through pretty carefully the last few days, like they talk very specifically about this point about a feasibility, I don't have to use the word feasibility study, but we need to understand how 911, like it's almost assumed that 911 in the talking points from Vibrant that platform is going to be integrated and used in collaboration with this new platform. So I feel like we're kind of stalled, waiting for Vibrant. And in fact, maybe we need to kind of like rethink the way that we're going about this. And again, this is kind of over my pay grade, so I apologize. But I do think that Adam's kind of convinced me that like there's actually more that we could be doing in the short term to really try to figure out what are we going to do? Because the reality is we're not 6 months from a platform. We're probably years from a platform. So like, what are we going to do come July?
Apologies, Jen, I was multitasking there for a second. Sorry, Betsy, go ahead.
Jamie, I just want to add one other piece is, I mean, those are great questions, and all 3 call centers have a way to collect data and answer calls right now. So that's not going to change. They're going to use their, ideally, we'd have new and upgraded sooner rather than later, right? That's going to help us get to the goals that have farther out dates around interoperability within 1477. But there is a starting place. We're not starting from scratch. The call centers all have technology and functionality now that they're starting from. So this is building on from that. So I just want to be clear, because I don't want people to think there is no way that data, that calls are collected, that call centers are handing off between, and it's not that it's super functional and it's not interoperable in the far as technology, but 911 call center handoffs are happening back and forth now as well. So there is a level of starting baseline functionality and technology we're starting from.
I'm going to pause for a moment. It looks like Ron and Bipasha have some contributions here. Liz and I have both checked our roster of participants and have not seen anyone who signed up for public comment still here. If you did, if you believe you signed up for public comment, and you are still with us, please send me a private chat and we'll make sure to make time to take your comment. In the meantime, we'll take Ron and Bipasha, and then I'll let you all know where we are on time after that. Ron?
Thanks, Jamie. Just to add some specific context to this discussion about the interoperability, it really, at least from my perspective, flows from an acknowledgement that there will be a small percentage of calls going to 988 that will rise to a level of crisis that was not understood at the outset or developed during the response. And that is where the critical need to transfer anti-alley data, the ability to say, hey, this event is occurring precisely at this location. 911 has that capability. That's what we're trying to figure out, is whether or not 988 will have the ability to receive that or transfer it, so that we don't lose time when we have to divert resources like first responders to a crisis that developed or wasn't properly identified because the information wasn't there. So it's a small percentage, but it's significant in that it could have, disastrous results if we don't get the right resources there. That's why we're talking about it.
Thanks, Ron. Appreciate the clarifications too. That's really helpful. Bipasha.
Just for what it's worth, I took a 988 call last year. Surprised me, and because I think T-Mobile made it live, and so T-Mobile clients, when they dial 988, it happened to land up at the crisis line that I'm working. Obviously, I don't know on what basis they routed it to us, if it was based on, right now the National Suicide Prevention Lifeline goes on your area code, your phone area code, so it routes it. So I have people call me from Arizona who used to live in Washington, and we have to walk them through and try to get a local crisis line. So there are obviously issues on figuring out where people are, and right now the crisis lines don't have the best or most accurate way of, unlike 911, determining where people are. So, but I'm just letting you know that the phone will ring somewhere. It may not be the best response.
Thank you, Bipasha. I just received a chat from a member of our community that I want to share with all of you. I think this is a really good way to sort of close our meeting. This is a member of our community who participated today and who sat with me in the main room and engaged in our discussions. It says, thank you again. Thank you to the committee for all of your hard work. The mindset of this committee gives me hope about the future of Washington State Crisis Services as a manager and provider. Thank you all. Felt like that was very important for all of you to hear, because this is a long meeting and you've put in a lot of brain power today. Let's see. All right. Any other comments on this? I don't see any hands up from any of our community members to speak. So I think we're going to be pretty close to wrapping things up. Claudia.
I just wanted to bring up one more time. I know representing people of color, our responsibility is huge at this point. If we roll out a system that's across Washington State to respond to the needs of communities of color. So I'm just becoming really concerned to making sure that we really see what could be the impact, because if we roll out something that is not something that will include access for communities of color, we can wipe out a whole system, not only in a local place. We're talking about Washington State. So I really call out for us to become really conscious about any of the comments I have done in all the small groups. It's very serious for us because I'm one person, right, who's speaking out for people of color. Please make sure that we have that in mind, because that will really affect communities of color.
Thank you for raising that, Claudia. So appreciated. Any final words here before I turn it over to Betsy we'll do some action items, next steps, and then we'll close it out. Yes, Representative Orwell.
I was just going to say, I feel so energized and hopeful from this meeting. I just want to thank everybody. It was just incredible discussions, and look forward to our next meeting. Thank you.
I so appreciate those words. That's a good way to wrap this up. In terms of action items and next steps, Betsy's going to talk a little bit about what's happening next, both with what we're doing with all of your feedback and some other detail regarding the ad hoc committee. So Betsy, I'm going to turn over to you now.
Sure. again, just really appreciate all the thoughts, both on the initial assessment and where we should go with the next iteration, as well as our subcommittee, our high-level work plan in partnership with DOH and HCA. HMA and the project team at BHI are taking all of these comments back. We're going to do kind of a scrubbing of our notes and make sure that we are creating we will be creating an issues log so that you all will see your thoughts represented as we go along. At future meetings, we're going to be, we're instituting this updates standing agenda item. You'll hear from DOH and HCA about implementation progress, and you'll also be hearing from the project team about how we are chipping away at the issues that we have to address. So I think you'll be seeing how we're moving through some of these issues that you've raised and incorporating them into our plans. So that's just a little bit of a housekeeping item. At the steering committee next week, we'll be bringing forward the high-level work plan for approval. If we're ready, we heard a lot of feedback today. We're going to do our best to kind of think about how we're incorporating all that and if it's ready for prime time. But the high-level work plan really is our way of starting to think about subcommittee charges and the work plans for the subcommittees. So we want to get that thing as dialed in as we can so that it's a working document that we can move forward in our work with the subcommittees. It also helps us drive the vision that we're going to be working on. And to that end, I want to say that at the steering committee next week, we will be taking a proposal to create this ad hoc work group for work on the vision that we mentioned earlier in the meeting. We're going to ask for a smaller group of our CRIS members to develop a proposal for the vision to bring back to this group so that we can nail down the vision and really work on that in more, with more intensity to really help us with the work that's ahead. So lots of agenda items for us for the steering committee and for future work for the CRIS. Just wanted to, share with you that there's a lot going on behind the scenes. We're trying to organize ourselves to really focus on the priority areas. So this is a little bit of the work that we've got going on.
Thank you, Betsy. Representative Orwell, any final words? I know you shared a few inspiring words, but any final words before we say goodbye today?
No, I think I could have shared it, but I just, I just really just want to thank everyone for being so engaged. And I know there's a lot of work ahead, but I just feel like we're really going to be able to tackle it and move forward. So thank you. Well,
I want to extend a special thank you to our community members who were here for the whole 3 hours and participated in our main room discussions. CRIS committee members, if you ever get a chance, we do record those and put them on the website. So please, if you find yourself with some free time, please take a look because we got some wonderful contributions, and we'll also make sure to summarize them and give you access to those outcomes because some great insights and stories coming from our community members today. And of course, as ever, thank you, CRIS committee members. Thank you, Michael and Jen, for sharing your stories today. Thank you, steering committee, for helping to lead this meeting and set the tone for it and set the context. I'm getting a lot of nice chats from people saying how much they enjoyed the meeting today. So your hard work today is very appreciated. Wish you all good health. I may see some of you next week at the steering committee meeting, but certainly at our upcoming subcommittee and CRIS committee meetings in the future. So everyone take care, and we'll see you soon. Bye, everyone.